Okay, good morning. Sorry I'm late. I gotta start leaving more time to get here because once I get in the building, there's all kinds of people want to talk to me. So, okay, we'll open up the public hearing on Senate Bill 47 and hear from the prime sponsor. Good morning, Senator Birdsell.
Good morning, I'm back. Thank you very much. For the record, my name is Regina Birdsell, State Senator for District 19, which encompasses the towns of Derry, Hampstead, and Windham. And I am the prime sponsor of Senate Bill 47. This was a request from the Department of Insurance, and this bill makes a birth mother's health insurance policy the primary policy for a newborn child's health care unless the mother has no insurance or coverage under the employer-sponsored health plan. Existing statute ensures that a child falls under their parents' insurance policy for the first 31 days of their life, and the insurance department has issued guidance on the application of the statute. So this is what they've been practicing all along. And this bill just codifies the fact that the department's interpretation. So with that, I will end my testimony, and I'll try and answer any questions, but the department is here if you have any questions about the coverage.
Representative Miles has a question.
Thank you. Thank you for taking my question.
Mhm.
I was asked to clarify if there is a young woman on her parents' policy, the young woman then has a child, does this cover the child too?
I believe, yeah, I believe the parents' coverage, if the young woman is under the parents' coverage, the
Then this
parents,
would cover the grandchild?
Yeah.
Thank you.
Okay, thank you
Thank
very
you.
much. I have no other cards. Yeah, do you want to just, yeah.
Thank you, Mr. Chairman. For the record, DJ Betancourt, Commissioner of the New Hampshire Insurance Department. I'm joined by Michelle Heaton, who leads our Life and Health Division. I know you all have a very busy day. We'll try to make this as quick as possible and ease you into things. Senator Birdsell, we really appreciate the fact that she was willing to carry this bill for us. And beyond that, she did a really good job of summarizing what we're seeking to accomplish here. It is purely a clarification of how we have always interpreted the statute. As you know, and I think it's hardly profound to say that, generally speaking, in our lives, the time when we are most vulnerable from a health perspective is when we're incredibly young and then when we're older. And so the level of consumer protection priority is raised when you're dealing with individuals who are in a vulnerable position. And so we really wanted to make sure that it was crystal clear what the dynamic was in these situations. And so that's what's prompted the bill to come forward. Beyond that, Michelle, is there anything you'd like to add? No. There you go. Happy to answer questions.
Nothing like housekeeping. Okay.
Beautiful.
Thank you very much. We'll close the public hearing on Senate Bill 47. And, we left too much time. Okay. Okay, we'll open up the public hearing on Senate Bill 121, notice of discontinuance of insurance. Who's the sponsor of this? Oh, okay, great. Yes, all right. Chair Grant Bossy, who will be here for Senator Avard.
Thank you very much, Chairman Hunt, members of the committee. My name is Grant Bossy, Deputy Chief of Staff with the New Hampshire Senate, here to introduce Senate Bill 121 FN on behalf of Senator Kevin Avard, the bill's prime sponsor. This bill came as a request directly from the Insurance Department to require insurance carriers to notifying the department when they cease writing an entire line of business or in certain circumstances regarding Medicaid Advantage plans. The department does not regulate Medicaid Advantage plans, but it finds it very helpful to stay informed on it as it serves as a clearinghouse for customers. It's intended to prevent confusion between the department and carriers in the future. The Insurance Department brought in an amendment that had been adopted to address concerns from carriers in the property and casualty space. I believe there is further amendment since this passed the Senate. Senator Avard supports that effort as well, and he thanks you for your consideration and support of Senate Bill 121. I will defer questions to the department and to the carriers. Thank you very much.
Thank you very much, Mr. Bossy. Okay, DJ. We'll have the
Thank you, Mr. Chairman, members of the committee. DJ Betancourt, Commissioner of the New Hampshire Insurance Department. So just very briefly, as some of you may know, this fall, the Medicare Advantage market experienced quite a significant degree of disruption. There are many complicated reasons for that. As Grant just cited in his testimony, Medicare Advantage is a product that we do not regulate. We don't regulate Medicare. We don't regulate Medicare Advantage. The only nuance to that is we do regulate Medicare supplemental or Medigap plans. That all being said, it'll hardly surprise you to know that the general public does not keep track of all of the insurance products that we do and do not regulate. And so as that disruption was taking place, we were inundated with calls from seniors, from family members of seniors who were getting these notices that carriers were doing one of three things. Either A, they were completely getting out of writing Medicare Advantage plans altogether. They were dramatically changing their offerings. In most cases, they were narrowing the number of plans that they were offering. And then one carrier, for reasons that I've still not yet been able to quite figure out, decided that they were no longer going to write in Stratford County anymore. I'm not sure who in Stratford County aggravated that company, but they decided they were not writing in that county anymore. The problem for us was we were getting in calls from consumers, from brokers and agents who were saying, what's going on here? And because the companies were doing slightly different things, we really didn't have a good sense as to what we should advise the consumer to do. At all possible, at any time possible, I always try to avoid sending the consumer off to the federal government to get information and advice and feedback. They're just not very responsive. So we always try to be as helpful as we can here at the state level to avoid that. And so as part of that experience, ultimately in the end, my deputy commissioner and I spent 6 hours one afternoon personally calling all of the carriers that we knew that were offering Medicare Advantage plans and asked them what they were doing. And finally, at the end of that exercise, we were able to have a better sense as to what we were going to tell consumers based off of what was going on. Either the carrier that they had was no longer writing it, maybe the carrier that they had was no longer offering the same plan that they had, or if you were in Stratford County with that one particular carrier, you had to pick something else. So we were finally able to get that clarity. So out of that experience came this proposal, which is to say, we don't regulate Medicare Advantage, as I've said, but what we do is license the companies that offer Medicare Advantage plans. And so what this legislation does is says, as a condition of that license, in the event that you are going to cease writing Medicare Advantage or are going to substantially change your offerings, you just need to let the department know what is happening. And that can be as simple as dropping me an email. It does not have to be anything overly burdensome or cumbersome. We just want that notification piece so that as consumers, are coming to us, we know best how to advise them or direct them. As was referenced, we took that concept and applied it to carriers in the property and casualty market. That was actually contained in our technical correction bill, which you have already dealt with. And so this is the last piece of that notification effort. So that is the genesis of the bill, and I'm happy to answer any questions.
So just to make sure we all understand that, if someone was not an Advantage in Medicare, there would be a regular insurance company in the state of New Hampshire. They would not be able to pick out a county and say we're not doing it because we have network adequacy requirements that is statewide.
That's right. Yeah, Medicare Advantage does not have, they have networks, but I don't think that they've got the stringent network adequacy requirements that you would see in a major med product, but Michelle will clean that up if I've gotten it wrong.
So in order to sell major med, you do need to meet the network adequacy requirements in each county. So there are certain plans in the major med market that do not write in all counties because they don't have adequate networks for all counties.
Right.
And they're allowed to do.
Oh, that's right. It was hard. I'm not supposed to mention names, but was not in the North Country.
There's definitely at least one carrier that is only offered in limited number of counties because they're trying to build up. their
So
network.
counties is allowable to
Yes.
even under state law they can.
Yeah, and
pick
it's
on a
usually
county.
tied to network adequacy.
Right.
If they don't have a adequate network, then we wouldn't want them selling because the people in that county wouldn't be able to access care.
And in network adequacy, which I think is important for the committee members to all get a feel for what the issue of the network adequacy, meaning that you can find enough providers who will sign up and ink a contract with the insurance company. And so therefore the reimbursement and the compensation has already been predetermined long before you show up as a patient. So that if let's say a certain county, that all the providers in that county wanted to boycott a certain insurance company, they could do that by simply refusing to sign contracts with them.
I think there'd be some antitrust issues there, but yes.
Yeah. Okay, Representative Gibbs.
Thank you, Mr. Chair. This is a very elementary question. When you say no longer writing policies, does that mean they will not write new policies for new customers, or the policies of current customers will be canceled?
So in the context of what we're talking about here, it means that they're going to finish out the plan year, and then after the plan year, they're no longer going to offer those products any longer. So they're not canceling current in-place policies. It means that those policies won't be available for renewal, or they cannot sign up for them again at the end of that plan year.
Follow up, please.
Further questioning may inquire.
Thank you. So the policy then would not be available even to current customers after the end of the year.
That's correct.
Thank you.
You bet.
Right. And we were discussing that when we did the Medicare Advantage program analysis, was that given the complaints about people switching back and forth between the plans, that Medicare Advantage just have one catch, which is once you choose to be an Advantage, you've got to stay an Advantage. But yes, it's only a 1-year policy. And if you might remember, I asked someone who was testifying, I said, why haven't you chosen a different plan? And which she easily could have done that because we're required to sign up every year. You have to sign up for that plan that you're choosing. Was that what you're going to represent, Spear?
In looking over the comments that were made during the Senate review, I saw comments that several of the reinsurance organizations had some problems, and one of them was about the 120 days. And I noticed that it has not changed. Is there a reason what's happening with that?
Sure. So I know that one of the concerns that was raised actually pertained to the other provision as it applied to P&C carriers. We fixed that issue. We may have even fixed it with all of you here in our technical correction bill. So those issues have fallen away. In terms of the notification piece, it was really us trying to be consistent with what the federal government requires and then typically what our rules require in terms of notification. Our rules are pretty uniform in the 90 days, so we went with that. The federal government's 120, and I think we addressed that piece too.
Yeah, I think we have an amendment drafted, and I think we were gonna introduce it in the work session, to change it to 90 days so that it's consistent across the.
So good question.
Everyone's
And
okay
yes,
with
we will be amending this bill in subcommittee.
I was a little sad. I liked the shorter period so that we found out before the federal government did, but they didn't like that. They didn't like giving me the sneak peek. Oh, well.
Okay, Representative Rose.
Thanks for taking my question, and I hope I didn't miss this. Is there any teeth in the bill in terms of if a company doesn't comply?
Yeah, because we've tied it to, as a condition of their license, should they choose not to comply in a flagrant way, then yeah, their license would be at risk.
They could also be fined.
And they can be fined. Doesn't have to be the death penalty, if you will, of pulling their license.
Right, but if you're
There's all sorts
right,
of other
well, that's
things in
assuming
between.
that they have some other products they still want to continue in the state. But if that was the only product they were selling, then
Vast majority of carriers,
then we need a fine, right? Then we need a fine.
vast majority of companies are offering more than just that. So we've got our hooks.
Okay.
Thank
you
you
very
so
much. And Paula Rogers, representing AHIP in support of the bill with amendment.
Well, there's a question about that, but let me say
Oh,
good morning first.
okay.
Representative Hunt and members of the committee, thank you for giving me an opportunity to speak about the bill. And Representative Spear brought up the fact that there was some concern about that notice period. So I've been in conversations with the insurance department. I believe they're poised to agree that the notice at the state level should align with the notice at the federal level. And so 90 days rather than 120 days was the request in the Senate. And so I'm looking at them and they're nodding their heads. So it's a matter of getting you language, apparently. And I probably dropped the ball or somebody, I don't know. We knew something was coming. So we, if the 90-day amendment were to be approved, would be entirely satisfied with the bill. It just seemed reasonable to have that adjustment made. And then there is this background issue, which is very important to plans that write in states and are regulated by states and regulated at the federal level, all around federal preemption. And I hate to even bring it up, so I'll drop it aside and say that any concern with federal preemption is certainly vastly addressed by that one adjustment to 90 days so that the notice period is replicated in one place and the other.
Okay. So I hope to subcommittee this next Tuesday.
Fine.
So
I'll
you
certainly
guys
work
will
with the
have that all
department.
worked out for us by then. Okay.
Thank you.
All right.
Thank you very
Thank you very much. Having no more cards, we will close the public hearing. Who am I bringing tomorrow? Sorry. Okay, we'll open up the public hearing on Senate Bill 124. And what's that? No, 147, sorry.
47.
Two. What am I doing? I'm looking on the wrong piece of paper. 247, okay. Phew. All right, 247. And Brian, you can't be a prime sponsor of a Senate bill.
I'm not a prime sponsor. I'm just
Okay.
doing it for him.
Okay. All right. Representative Cole is introducing the bill.
For the record, Representative Brian Cole, Manchester, New Hampshire. Senate Bill 247, prohibiting network exclusion for pharmacies that refuse to dispense a prescription of PBM reimbursement that is below pharmacy's acquisition cost. On my way over here, kind of thought about what I was going to talk about. And I know that Carrie Spear and I, we sat on a special committee about PBMs last summer. And basically what this boils down to is saying the pharmacists don't have to sell a prescription below their cost. I mean, it's basically what it comes down to. I don't know how much into the weeds you want to get into this. I know there's a lot of speakers behind me, but I'm well versed on this. I think this is a good compromise. I think it's something that everyone could live with. This is a subject that's come up a lot of times. And I think I'll leave it at that. I'll answer your questions because I know a lot in the committee have heard this many a time. So ask me your questions. Yeah.
Okay. Could you provide a simple example? Someone goes to the pharmacy, they're at the register, and you can use Tylenol. I don't care. Just something very basic.
So you have drug X, and it is the PBM tells the pharmacist he has to sell it at $10, even though his acquisition costs for that drug may be higher. So he's selling it at a loss. So it's kind of unfair business practice. We don't go into business selling product at loss. Does that make sense?
And so the consumer purchases it at,
They're forced to it because they sign a contract with the PBMs. So the
they're forced
PBMs,
to pay the higher price.
the pharmacist is forced to sell the medication that the PBM tells them to sell it to, even if it is at a loss to that pharmacy.
So what is the patient paying at the register? The lower or the higher?
They're paying higher.
Thank you.
Representative Sullivan.
So I guess my first reaction is if a pharmacy wants to not pay or sell, I mean, what you're saying makes sense. We don't want to force somebody to sell something at a loss. But then again, isn't it their option to sign this contract with the PBM? Or are they forced to sign the PBM? I mean, if they think in general, being a membership of this PBM is good for their business, even if that means sometimes you have to sell something at a loss, presumably that's part of their business decision, right?
At this stage of the game, yes. I mean, overall, because they have to get the medications from the PBMs, they have to get through the wholesalers.
Mm-hmm.
The PBM's kind of the middleman. PBMs don't have the skin of the game. Consider them like a retailer or a realtor. Okay. They're not holding the inventory. They're just the middleman that's going from the wholesaler to the pharmacy. Okay. They contract with those prices. And those prices are set for a specific amount of time. And they have to hold those prices. Now, if the PBM tells you at some point during that time that you have to sell it at a lower cost than you had originally contracted for, you're obligated to do so.
Follow up.
Further question may inquire.
So if you have in this, what you just said was that if somebody signs a contract with a PBM and they have some sort of contracted price, and at some point they decide it needs to be lower, then they have to now, is there some sort of clause in the contract that says, hey, we can drop the price on you? Like, you might be thinking you're getting $1 pill, but we're going to decide you can only sell for 50 cents a pill. And that's like, the contract allows for that.
Mm-hmm.
So what kind of contract is this that it can just change on a whim? Like, we decide we're going to drop the, like, why would any reasonable business sign a contract where they don't know what the prices are going to be contracted on in the future if it could just change on a whim? There has to be more to this than that.
Well, that's kind of the conundrum we're in.
Okay. So would you believe?
Here we go. Story time.
So way back many, many, many moons ago, this committee was overturned on the House floor, where the issue was that that the the patient, or I would say the insured, could get a prescription drug from the pharmacist, even though the pricing was set by the PBM for them to get it mail order. And the issue was that if the pharmacist is willing to match the price that the mail order company was going to charge, shouldn't they have that? And that was what we would put in the category of any willing provider. Anybody can provide the service, not what was contractually arranged. And this committee was overturned. So that happened so long ago. I mean, I can say Donnelly Lozo from Nashua who was the one who overturned this committee. And it's been on the books all this time, which is probably just fine and dandy. No, it was never any problem. No one had any complaint. There was no issue to it till now. We get a position where now the mail order company and the arrangement of the PBMs of trying to get the best price are now able to actually sell that price below cost. And I asked, the pharmacist, I said, are you ready, prepared to sell it below cost? Are you're passing your mandate that we're going to allow you to, do it. Are you really going to do that? And they said, well, we do like having the customers come in. We're doing a customer service to have the customer come in and do business with us. So there was never any mandate that said that the person had to buy it from a pharmacist. The pharmacist wanted that legislation simply so that if you didn't want to get it mail order, you wanted to get it, have somebody come in, wanted to get it, they theoretically at that time understood the consequence that they might have to sell it on below market. So that's why I was a little surprised when this bill popped up and this issue came out of that committee, because I'm saying is, wait a second now. So now they want to go back on that promise that they would be willing to accept a lower price. But at the end of the day, yes, you can get it that right price, but yes, you would have to buy it mail order, not through the mail rather than through a pharmacy.
And what this bill is saying, the pharmacist can refuse filling that prescription and they can go through that service. You're not forcing the pharmacist to sell the medication at a loss anymore. That's the crux of this bill. And what Chairman Hunt is talking about is a land 30 years ago when the landscape was much different than it is today. This applied to 10% of the generics back in the 80s. Today it applies to 85% of the generics in the market. It is the market. Okay? Mm-hmm. There's a big distinction there. The other big distinction is there's only three PMs that control 85% of the market today.
Yeah, thanks.
Okay, so we'll start with Representative Miles. I saw her hand first, and then Representative Ammon, and then Representative Gibbs.
Thank you, Mr. Chairman. Thank you for taking my question. If it's something that you can't answer, that's fine. I'm sure
There's
someone
plenty of experts
today
behind
will
me.
be.
Yep.
So the pharmacy benefit manager makes out. The pharmacy is able to sell at the higher cost, and sounds to me that the consumers are the one that will be losing out at the point of sale. Is that correct?
I'll be careful in answering a question I would say is driving consumer prices higher. Is that the correct?
Right, but I would say, based upon the scenario I was saying is, that if the pharmacist says, listen, I can't sell you to that price, I'm going to charge you more. I assume the pharmacist would say, however, if you got it from the mail order company, you can get it at the lower price. So it's just a matter of how bad you want me to be the one who fills the order versus getting the order filled by a mail order company.
But
Follow-up?
you want to give that
So would
pharmacy
that-
Further
the
question.
opportunity to do that, right?
So the small pharmacies that are not the three big PBMs are also losing out. Yes?
Well, in terms of we break pharmacies down into two different categories: chains and independents. Okay, I assume this issue is more for about the independents, because I assume the chains they don't mind losing money because it's in the scheme of things that's just the nature of their business. Right? Evidently, that's why they're all going bankrupt. So this is about independents who want to be able to fill those orders, and they don't have that negotiated price with the PBM because they can't give the volume. They don't have the volume of customers. So
One more follow-up.
further question.
So would you believe I don't see anybody benefiting from this except the largest PBMs who are owned by the largest insurers?
And that's a would you believe?
Glad I don't have to answer.
Representative Hammond is next.
Mr. Chair, thank you for introducing this bill. I have a question about, I just have it on my screen here, the exclusion for Medicare and Medicaid. In other bills that we have, bills that have mandates, we learned that that's 80% of the market, basically.
Well, it was to ambulances. It was 80% of the
To
market.
ambulance was 80%.
Okay.
But it's the private insurers are a much smaller section.
So we cannot legislate
I know we
anything
can't.
we
I
get
know we can't.
related to that.
My question is, by excluding that, does it put extra pressure on the rest of the market? And how does that dynamic work with that exclusion? That's my question.
Representative Ammon, I think that is better answered by somebody behind me.
Okay, now Representative Gibbs.
Thank you, Mr. Chair. Excuse me. Doesn't the bill provide a slightly different alternative, that rather than selling the prescription drug at the higher price, that the pharmacist can inform the patient that essentially they're not going to sell them that drug, and they should contact the pharmacy benefit manager to find out where they can get it?
Representative Gibbs, you are absolutely correct.
Thank you.
Okay, Representative Sullivan.
So I think I understand the crux of this issue, but let's say that I really like going to my pharmacy and, they want to charge me $10 and the cheapest price that the PBM is going to pay, or you could get it for, is $8. Is there an option right now to say, all right, I'll have to pay a little bit extra out of pocket, but I want to continue going here because I can get it today versus having to wait in the mail? Like, is that built into this system, or is it going to be, it's either this and you don't get any insurance coverage for it, or if you want insurance coverage, you have to go through this other system?
Is Glenn here? Glenn, do they have an option to pay a premium at the point of sale? No, you'd have to go through the mail order system.
So we are taking away an option to get it from the stores then.
From that direct supplier at that moment in time in your life, yeah.
Okay, thanks.
Only at that price. If you want to pay for a lower price, then you have to go through an alternative.
Right. The end of the day is the consumer, if they're choosing to come in to a pharmacist, and that is, knowing full well, and let's talk, a lot of this is maintenance drugs, things that you get every month. And so the issue is that, but this consumer prefers to come in and get it from a pharmacist. That the problem is that pharmacists can't get it at the volume. They're not doing the volume. They're not doing the pricing that the mail order is able to provide it at.
No, I understand that. I'm just curious if, or maybe it would be better if somebody likes going to the pharmacist to be able to say, like, if you want to pay a premium, that could be an option. It sounds like this would not even be an option. It's either pay 100% out of your pocket and buy it at the pharmacist, or go through the PBM. And I wonder if there's a middle ground where you could say, all right, if you want to pay the premium, you can pay the delta between the PBM and the
Right.
the
So that
pharmacist.
bill does not address that. I thought it was going to address that, but I don't.
Doesn't sound like it from
Yeah.
what I just heard.
So,
No, that's interesting though.
not much of a solution then. Okay, now let's see. I saw Representative Burrows, and then Representative McAleer, and then Representative Cerisa.
Thanks for taking my question. I apologize if it was answered while I ran out to take a call about medication that I'm having trouble getting. And this is my question based on that, is that I am out of medication right now and I'm going crazy trying to get it because they're saying, well, you got to get it through your mail order. I don't want to wait 5 days. So does this put the consumer in a bad place in terms of getting something that they need quickly and having to wait, which is what I'm going through right now?
I would say yes, it would.
Well, let me tell you, it really,
Would you believe?
would you believe, I'm trying to come up with a nice word other than sucks. It's not, and I can't think of one. It sucks. Thank you.
I would say that if you wanted to
just
travel
not
to another
right.
Representative Burrows, if you really wanted to travel to another pharmacy that was willing to provide that medication, whether it be like an hour and a half away, if you needed that instance, you'd probably have that option.
She doesn't have to drive that far.
Well, I don't know. It depends on where you live, right?
Representative McAleer.
Thank you. Just let me clarify something. As I understand it, it's not mandatory. People seem to think that it's mandatory. So if I go into a pharmacist and I'm a good customer there, he might sell it to me at the lower price. But somebody who might not be a good customer, he might ask for, the additional $2 to cover his costs. Is that correct?
I don't think you can ask. I think Glenn just said that you cannot ask for a premium on top of the product. You're going to have to go in an alternative place to get the medication at that time, unless the pharmacist is willing to sell it to you at a loss.
But that's up to the pharmacist to decide that.
I would say that it's up to the pharmacist's discretion,
Well, it
right?
gets- we'll put him on the hot seat now. Next.
Yeah, all right.
Thank you.
Okay, Representative Gibbs.
Thank you, Mr. Chair. Okay, I think I misunderstood one of your earlier answers because it sounded like you were saying that if the pharmacy benefit manager mandated $10, but the pharmacist cost was $12, that the pharmacist could sell it to the patient for $12. But now you're saying that that's not possible.
No, that's not correct. If the PBM tells them, the pharmacist, they have to sell for $10, they have to sell for $10, even though the acquisition cost is at $12.
Follow-up question. So then the patient has to go somewhere else.
If the pharmacist is unwilling to sell them to them at a loss, yes, they will have to.
Okay. Thank you very much.
Thank you. It's
Did
good seeing
you-
you all again.
Okay, so Glenn? Since you are a supporter of this bill, you can help unwind this for us.
Hi, my name is Glenn Peralt. I'm the owner of Colonial Pharmacy in New London, New Hampshire. And I was testifying extensively before the PBM committee all summer long. Testified in support of this proposed legislation, SB 247. And so I'd like to testify today and support this legislation with amendments. The original proposed legislation had a stipulation that read that nothing in this section shall prohibit a pharmacist from charging the patient the difference between the pharmacy's acquisition cost and the total reimbursement from the PBM. That was eliminated from this piece of legislation when it went before the full Senate floor. I would like that reinstated into the bill because it's the main crux of the bill. The intent of the bill, as I understood it, was to allow me to continue to fill prescriptions for my patient population. Pharmacy has been a very altruistic profession, but up to this point, we cannot bear the losses that we're incurring. And so with the language of the PBM negotiations, they're not contracts, they're stipulations. There is no back and forth when you either accept the PBM contract or you don't. And in that language, they say that you have the drug on the shelf, patient comes in for the prescription, you fill it. No ifs, no ands, no buts. The example that Representative Cole was giving of a $10, $12 is grossly understated. We're talking prescriptions that cost anywhere from $1,000 to $1,500 that we're being underpaid anywhere from $50 to $200 on. It's unsustainable. Just can't do it. So I believe that it is very necessary for patients to continue to obtain their prescriptions in a timely fashion without driving all over the state, without waiting for mail order that is often exposed to temperature extremes, that this legislation is necessary. And I'd be happy to entertain any questions.
Representative Spear.
You mentioned that the Senate took out that particular wording. Were you there? Do you have any idea why they took it out?
I do not know. After I testified before the Senate committee, and I think it passed out of the committee unanimously, I did not follow the bill after that.
Representative Sullivan.
I'm sorry, but I actually walked in as you were explaining that language. I had to run to the restroom. So I just was curious, it sounded like it might have been something that would allow you to add the difference between the two, and that was taken out? Is that what?
Correct. And that was the crux of the legislation. That was what I wanted to see in there so that I could continue to provide these medications to my patient population. Right now, myself, as well as many other pharmacies, not just independents, but chains as well. I invite you to walk into a Rite Aid and take a look at the shelves and see what they have there. It looks like Mother Hubbard's cupboard. It's very bare. They're not stocking these medications. They're not filling prescriptions for these medications because of that huge delta in the cost of the medication and what we're being reimbursed. I've heard it mentioned, why would any pharmacy sign up to be part of that? Well, it's lives. Like someone was referring to, believe it was Representative Cole was referring to, these are the three largest. There are three PBMs that control about 85% of patient lives nationwide. So if we don't sign a contract, we don't have access to any of those lives.
Further question may inquire.
So you would like to see language perhaps reinstated into this bill that would allow you to at least offer the patient the medicine if you could collect the delta on top of what the insurance would. Is that what you're saying? You would
Correct. And it's not the delta plus a dispensing fee. It's the delta. So
sure.
That's all about. I'm just asking not to go
just
broke.
You're made whole, essentially.
Correct.
Thank you.
Representative Teresa.
Thank you for taking a question. So if I understand correctly, the acquisition cost for the drugs will be different for each pharmacy, correct?
That's correct.
Further question?
Further question.
So in that event, when they sign the contract, they know what they are getting into. So would you believe that if out of, let's say, if they're selling 10 drugs, probably majority of that, 80%, the insurance company or the PBM, they are paying them fair amount, maybe 20% or a couple of them, they are underpaying them. And is that a scenario, or is it the other way around? They are paying less for most of the drugs. What is your assessment?
So you can't go by just the number of prescriptions. For example, unfortunately, I just had to find a patient a new pharmacy. This patient filled 10 prescriptions with me. Of those 10 prescriptions, 8 of them were generic. 2 of them were brand name. From the beginning of the year through March, on that one patient, I was underwater by $496. The reimbursement on generic prescriptions is pennies on the dollar and does not overcome the underpayment on brand name drugs. I actually go, before I take an action like dismissing a patient from the pharmacy, we look at their entire profile to see if they're profitable or not. We look at a spouse to see if the 2 of them are profitable or not. We look at the family, the children, to see if the whole family is profitable or not. The pets, in some cases, to see if they're profitable or not. And in many, many cases, the underwater reimbursement on brand name medications is so low, we can no longer provide services to that family.
Last follow-up question.
I'm getting really close to, I know what question I want to ask and get to the heart of the matter, but I'm certainly willing to let everyone else ask questions first.
Okay.
So, Representative
you.
Miles, if you have a question that really going to be just a short answer, then, okay, go ahead.
So, who's since the acquisition cost is going different for each pharmacy, who is going to administer or manage those acquisition costs? How would somebody know that this is acquisition cost for this pharmacy versus other pharmacy, or they can just give their prices?
So there is a published price out called WAC. WAC stands for Wholesale Acquisition Cost. It's what the wholesalers pay for prescription medications. That's one alternative. However, I think the most accurate measure, because even myself, I buy medication from my wholesaler at 3% below their cost, is using NADAC, which is a national published pricing information sheet. It's National Average Drug Acquisition Cost. And it's a survey of independent chain big box pharmacies of what they actually pay for their medications. And so when I have access to NADAC and many times when I look at my prescription drug, my brand name drug purchases, it shadows NADAC, which is about 3% below WAC.
So,
Thank you.
Representative Miles?
Thank you. Thank you for taking my question. So as the legislation is written, without the amendments, who benefits the most from this?
No one benefits from this. The patients do not get their medications. I probably lose a patient. The only beneficiary to this I can see is possibly an insurer or a benefit manager who steers that patient to their own pharmacy or to a mail order
Bingo.
pharmacy.
Thank you.
Okay, now, thank you for asking that question. So let's and the committee is used to me telling a story, so, bear with me a little bit. Okay, the heart of this issue is that the reason why insurance companies created PBMs is that they wanted an entity that they can blame for when everybody's freaking out about prices, okay? So they have an arm's length. The PBM's fundamental purpose is to get those drugs as cheap as possible. How do we know how to do that in a capitalist market? It's called you make it up in volume. That's where you get your discount. Clearly, an independent pharmacist, even though they're using this new concept that I've never heard of, these PSAOs, okay, are helping them administrate it. The end of the day, the reason why your health insurance company / PBM wants you to get it from mail order is because they get the best price because of the volume discount. So the issue is, and you really said you nailed it when you say the difference between generic and name brand, okay? Because that's where the price delta really is the big problem, is things that are not generic yet, okay? And so why does even chains not carry this product, whatever? Because most people who, and these are, I'm talking maintenance drugs most of the time, that the reason you're getting it from that mail order company is because they were able to get the best price for it. That's where the issue is with this legislation. That's where we get down to why does mail order exist at all? Is simply to have lower insurance premiums. So who makes out? Theoretically, yes, the customer makes out, or their employer who gets the insurance plan, is that the premiums are lower. If you pass this kind of legislation, notwithstanding that we could maybe address the generic versus the name brand, okay? But if you pass this legislation, that means if it's no difference in the consumer in terms of coming in or what they're buying something from the independent pharmacist who clearly is paying that huge difference in price, okay, is affecting ultimately the insurance company's costs on pharmaceuticals, because the insurance companies want you to buy it mail order.
Where are you getting that information from?
I invented it all on my own.
But therefore, we're hurting the people at the end of the chain, the customers at the register who want to get their drugs at their local pharmacy.
Again, this committee was overturned many years ago when we pointed out that does that one customer care about what the premium is? Maybe, maybe not. But at the end of the day, if we created this model that says we want to get that drug as cheap as possible so that our insurance premiums are as low as possible, you can't then say, oh, well, for convenience sake, let's override that, because ultimately the insurance company, that's saying is that, well, in terms of paying the delta, paying the price, the insurance company says is, well, now if everybody chose that, everybody decided to not go mail order, everybody chose to go and get it from their independent pharmacists, now that wholesale, that manufacturer, where they're getting that product from, okay, where they gave them that really low price because they were making it up in volume, they're going to raise their prices.
They're getting it at a cheap price, but they're not selling it at a cheap price.
No,
The
that's-
PBMs are making the money. The insurance companies are making the money. It's not good for the consumer. It's not good for the independent pharmacist.
And that's
Sorry.
That's what you believe. So,
Mr. Chair,
Representative Gibbs, you have a question?
it's more of a question for you, actually.
Yes.
In considering this, don't we have to take into account, in addition to the financial issues, the issue of the extra hassle for the patient in dealing with mail order? And I can tell you, this is from personal experience. At one point, a doctor told me that I could get the medication he was prescribing cheaper from mail order. And the hassle was so extensive that I stopped doing it and began dealing with a local independent pharmacy, which essentially eliminated the hassle completely.
I would say you need to change your insurance company because they have a lousy PBM.
With
I
respect,
cannot change my
they're all the
my
same.
insurance company. It's
I believe you're over 65.
It's written
You can-
into my retirement plan.
Okay. So that we really couldn't affect that, and even this legislation wouldn't affect that either.
if you added the
if you're
amendment
in a
back
ERISA
in that
plan.
allowed her to pay the delta,
She was
it-
in a RISA plan. It doesn't matter.
it
We
would.
can't affect that.
This a PBM, it's already been, look up Rutledge versus PCMA. You'll see that this is could be preempted. ERISA could be preempted in the case of PBMs because PBMs are contracted by insurance companies. PBMs have no fiduciary responsibility towards the plan. I believe that was an 8-0 decision by the Supreme Court. But there was another part of this legislation when it referred to PSAOs, and I think there's some confusion using the blanket term PSAO. PSAO is a very generic term. There are certain PSAOs that will bundle insurance plans and provide reconciliation with insurance claims. Then there's a different type of PSAO which bundle items, drugs, over-the-counter items, vials, labels, that have nothing to do with negotiating with PBMs. So I just want to put that out there that the companies, the PSAOs that I've dealt with 3 in my pharmacy career, they have nothing to do with price on medications. It is the buying groups that a pharmacy belongs to. So,
You're saying they're not necessary to be in this legislation?
No, I'm saying that I don't know what this legislation is trying to achieve. It describes what PSAOs are.
Right. So my understanding from the sponsors that the reason why that's in here is that the PSAOs are a convenience for you independents.
Correct.
And that the unfortunate element, and there's only a handful of them out there, and they all seem to be appeared to be owned by wholesalers, and that once you sign an agreement with one of them, you cannot get another one's different if it has a better price or not, but you are free to switch around between which one you operate with, but they do hold an exclusive of getting their pharmaceuticals from their wholesaler.
No, that's incorrect.
Okay.
So for example, I'm going to use myself as an example. My wholesaler is Cardinal out of Boston. Their PSAO is called LeaderNet. They bundle my insurance plans and they provide me with my reconciliation. I now have a contract with American Associated Pharmacies, which is my buying group. Has nothing to do with LeaderNet. American Associated Pharmacies puts out RFPs through the 3 largest wholesalers, McKesson, AmerisourceBergen, and Cardinal. As of now, I'm with Cardinal as my drug provider. Has nothing to do with my PSAO. Has everything to do with AAP. And there are other pharmacy buying groups out there that bundle or have as members thousands and thousands of independent pharmacies. My group has around 3,000 pharmacies as a buying group. Not small. It's approaching the size of Rite Aid. So we do have, or I should say AAP has a lot of buying group, buying
Glad to hear that you guys have
leverage.
that. That's great. Good. Thank you very much for your testimony.
Mr. Chairman?
Oh, Representative McLeod, I'm sorry.
Thank you. You heard my conversation with Representative Cole, and it turned out my assumption was incorrect. The assumption was that if the drug cost 10 and I paid 12, I could negotiate with the customer and get them to pay 12, or we could compromise at 11. You said something when you sat down about they basically amended that out. Is that correct?
Correct. The original 247 as introduced, Roman numeral 5, was in the original legislation, and when it came out of the Senate, that stipulation was removed from the legislation.
But the way that I understood it is
Further
the way
questioning,
that you wanted it, correct?
I do want this, and I believe my patient population would jump at this because I'm constantly getting asked, well, can't I pay you the difference to stay here?
You're saying you really want that paragraph back.
Correct. I would like
That's
that
what,
back.
to clarify is that
That's
you
exactly what I tried to say, and
I
why
know.
can't we just take that amendment out?
right. What he's surprised is why would you be supporting this bill as is if you really want with this amendment?
No, I'm supporting. I was supporting with I'm supporting this bill with the amendment of this added back into the legislation.
Right.
Got it.
Because that is, in my opinion, that is the crux
That
of
is the
this
heart- that
medication,
absolutely is
of
the
this
heart of it.
legislation. Without that statement, it does patients absolutely no good.
I think this would answer Representative Miles' question in that there would be benefits to the pharmacist and the client if they could negotiate this. Thank you.
Okay. Thank you very much. Okay, Michelle. The department is neutral, as they would be on any health insurance mandate.
Good morning. My name is Michelle Heaton. I am the Director of Life and Health at the New Hampshire Insurance Department. I'm just going to do some level setting here. Prescription drug costs are one of the leading drivers in healthcare costs, as well as the increase in health premiums. So it is something that at the insurance department we are watching constantly, and is a big part of our annual hearing on health insurance cost drivers. This issue about this delta everyone's been talking about, the difference between the acquisition costs and what it costs the pharmacist, is not a new issue. It's been around a very long time. There's been a lot of work groups, committees, various work sessions that have been discussing this issue for a long period of time, not just in New Hampshire, but across the country. There are a lot of issues with prescription drugs, and this bill is not going to fix all those issues. This is an attempt to fix one issue. What this bill actually does, because I think there's some misconceptions with this, is that it is amending 420J. 420J is our managed care law. This is not regulating PBMs. This is regulating the prescription drug benefit under commercial insurance plans. It has no bearing whatsoever on ERISA plans, Medicare, Medicaid, or uninsured population. And what this provision is actually doing is it's allowing an in-network pharmacy to decline to fill a prescription if they're not going to get reimbursed at their cost. And they would direct the patient to call their insurance company or a PBM to figure out where they can get the drug. There's also another section that's that amends the Consumer Protection Chapter 358A. And that is to regulate these PSAOs, because PSAOs are not something at the insurance department that we regulate. These are groups that contract with with pharmacists. That is not within our realm of what we regulate. That's why it's in the Consumer Protection Law. So the only aspect here is in 420J. So part of what 420J does is it's managed care. Care is managed, and costs for this care is managed by carriers entering into contracts with in-network providers. And that's how they bring down these costs. I think the amendment that was being referred to that took out that one portion kind of defeats the purpose of managed care, because there would be no incentive to contract if the pharmacist is going to charge whatever their costs are. Then there is no contracted rate anymore. So that's just one thing to keep in mind. So that being said, like I said, these are complicated issues that are being discussed across the country. There is no one approach any state or group has taken. So I know this has been discussed at length in various committees and work groups, and we're here to assist you once the policymakers have figured out the way to fix this. We're happy to help you put that on paper and put it in the right place.
That means us. We're supposed to figure this out.
Yes. I'm happy to answer any questions.
Okay. Representative Gibbs has a question.
Thank you, Mr. Chair. And thank you for being here to answer questions. So you said that the insurance companies or the pharmacy benefit managers would have a problem if we re-amended the bill to put back the provision that would allow the pharmacies to charge the patient at the level of their own costs. Would the department have any problem with our putting with our re-amending the bill to put that provision back in a way that, quite honestly, makes the most sense to me in consideration of the patient.
So I'm not going to speak on behalf of the carriers. They can speak for themselves. The department, we take no position on it. But what would happen is if the in-network providers are allowed to charge whatever their acquisition costs or the delta between that, then that would likely cause prescription drug prices to go up because there are no limits on that contract negotiation. So that's what we would expect to happen. But again, there's different ways of addressing this issue. This is one of those ways. And if that's the way the policymakers want to go, then, you can make amendments to make that clear. Right now, the way it's written, it does not necessarily do that. It just makes it so the in-network provider can choose whether or not to fill that prescription.
Follow-up question?
Further question.
Can you tell us why it would cause prescription costs to go up?
Sure.
I mean, I assume that pharmacies are not just going to charge, $1,000 for a $10 drug. That wouldn't make sense. And as our pharmacy owner testified, pharmacies generally want to help patients, and that also has been my experience with independent pharmacies. So why would prescription costs go up?
So part of the contract negotiations to get providers in care, generally speaking, is that they're negotiating a rate that they're agreeing to receive for treating these this patient population that the carrier is bringing to the table. So that is how they negotiate rates to keep overall healthcare costs down. If the provider does not have to charge that negotiated rate and they can charge whatever they want, then yeah, I think it's unlikely they're going to charge $1,000 for a $10 prescription because they're going to lose customers. But there could be, they're charging $12 or $13, and that defeats the whole purpose of negotiating a rate for those covered people to say, this is the max of what you're going to charge our covered lives.
Further question, please?
I hope you're listening to what she's saying, and that is that it's not the scenario you're making is that anybody's just picking a number out of the air and charging that number, okay? Listen to what I said when I said you make it up in volume. It's where you're getting the product, how much product you have, and what that's going to determine your price. Okay? So therefore, that's why we invented managed care. That's why everybody hates it, but this is the only way we've figured out how to hold down health costs is to have these contracts. And those contracts have a dollar amount written into it, and the person who's selling the product, the person who's providing they set their number based upon how many customers they're going to get. For the
Independent pharmacy can't make it up in volume.
That's the problem.
Well, but there are other considerations, as I mentioned. And by the way, with my insurance company, I have a number of prescriptions. Each one costs me $750 a month with my insurance.
Are you in the state employee ERISA plan?
Sorry?
Are you in the state employee ERISA plan?
No, I'm a retired federal employee. And I chose to keep my federal insurance rather than go on Medicare Part B because my federal insurance worked so well. If it works, why change it?
Yeah, great. Representative Miles.
Thank you.
But I didn't get the chance to ask my question.
Okay.
Sorry.
It seems like you keep asking the same question. So.
Well, no, I don't think so, and I think I am listening to what you said and what the witness said. But okay, if a pharmacy signs a contract and agrees to a price, shouldn't that change? Shouldn't that be able to change if the situation changes? I mean, suppose the pharmacy has a $10 cost and sells it for $10. And then the cost goes up to $20. The situation has changed. Shouldn't that affect the contract price?
It's my understanding that these prices do fluctuate all the time, and the reimbursement lists are constantly changing because there's fluctuations in the market. So they are constantly changing prices to adjust for those things.
But apparently they don't always cover the delta.
I don't know. I'm that's what I hear. But again, if that's the problem, there's ways of, looking into that problem. But this bill's not going to change that.
What would those ways be?
So some of it is outside of the insurance department jurisdiction. We have no jurisdiction over what prescription drugs cost or manufacturers or any of those things. One of the ways you could look into it more is under 420J, there are mechanisms for under which the pharmacist can appeal the decision of what the acquisition cost is. You can, put stronger provisions into that. There's more transparency. We're actively working, and we've been doing that for some time to get more transparency around this, around drug rebates. I mean, there's a lot of different levers, and that's why I say these issues have been talked about a lot in various sessions, and there's different ways of approaching the issue, but there's no consistent method that's being used across the country. I think everyone's trying something different to kind of see where things end up.
Representative Miles.
Thank you. Thank you for taking my question. So as a representative of the insurance department, you've stated at least 2 times now that you're not taking a position. Are you aware that you in fact have taken a position and you've been attempting to be very persuasive by stating that the amendment legislation that was previously taken out by the Senate is not a good idea? So I believe that that would be considered taking a position.
We don't take a position. I'm just telling you what it's going to do. So if you put that in, then that is, it changes the managed care. So currently we have managed care and in-network providers. If you want to go that route, then you can do that. I'm happy to help you fit it in where it should go in 420J.
That's
but
all.
It undermines managed
Right.
care in doing that.
Right. It's basically, she's warning us that if we do it, we are, the consequence is that we're raising the cost of insurance.
Yes, and she's exactly doing what she's saying she's not doing, which is taking a position.
Excuse me,
Yeah,
Mr. Chair, can we
I-
be a little polite to people who are testifying,
Yeah,
please?
I would urge, let's not question people's motives. Representative Sharisa.
Thank you, Mr. Chair. So my question is that I just want to understand, currently, if a person wants to go to a pharmacy for whatever reason, convenience or whatever reason, does the pharmacy has an option to charge the delta by charging
We've
extra?
already been
Copay.
through over this issue. That's exactly what
charging by-
that
by-
was the amendment that was removed from the bill by the Senate.
I mean, increase the
That he
copay.
could, but that we would have to put that amendment in the bill, put it back in the bill. That was the conversation that we've been having.
Increase the copay, charging extra copay to the patient.
We were,
Yeah,
yes,
I think
it is
under,
about the copay.
under the current way it's structured under 420J, when you go and fill a prescription, you pay whatever your cost sharing is. What that amendment that was removed, or the original bill that was then amended, in the original bill, it would allow the pharmacist to charge you more than what your copay is. And under managed care, in all contracts with all providers, there are provisions saying that you agree to accept as reimbursement the contracted rate, and you're not going to balance bill, and that you're going to bill them more than what you've agreed under the contract to receive as reimbursement.
Okay, thank you.
Okay. Thank you very much.
Thank you.
Okay, I got one more card left. Ali Mercurial from Healthcare Distribution Alliance, who is in opposition to the bill. And still morning, barely.
Good morning. My name is Allie McGarrigle. I'm with Sterling Haley. Thank you, Chair Hunt and members of the committee for the opportunity to provide testimony today on behalf of the Healthcare Distribution Alliance, or HDA, on Senate Bill 247. I checked off oppose on the card, really just looking for some amendments and speaking to a specific part of the bill. HDA is the trade association representing the nation's pharmaceutical wholesale distributors. HDA has submitted more detailed written testimony through the online portal, but wanted to come and summarize for you today some of our thoughts on this legislation. The primary goal of Senate Bill 247, as currently drafted, in my understanding, is to the pharmacy's right to refuse to fulfill a prescription if the reimbursement from the PBM is less than the pharmacy's acquisition cost. However, there are sections of the legislation which pertain to an entirely separate entity, the Pharmacy Services Administrative Organizations, or the PSAOs. Some of the language included in the legislation incorrectly defines PSAOs and includes some criteria that are not achievable for them. In our view, the PSAOs are not necessary to the primary goal of the bill, which is focused on PBMs. And we would respectfully request that the committee consider removing these sections. However, if the language regarding PSAOs remains in place, we hope to work further with the committee towards some friendly but critical amendments to ensure the legislation is accurate and workable. This is critical because of the specific roles that PSAOs play. They're optional administrative organizations that independent pharmacies may elect to hire for a simple monthly contractual fee. It's typically around $200 to help them manage PBM contracts and red tape. PSAOs don't retain a portion of the pharmacy's reimbursement. They do not set a drug's list price, determine formularies, dictate pharmaceutical reimbursement rates, or impact what the customer pays at the counter. Some wholesalers offer PSAOs as an add-on service for their customers, and some are independent. This means that in a given moment, an independent pharmacy has choices on the table. They can choose to handle their PBM relationships and contracts themselves. They can choose to work with their wholesalers PSAO, or they can choose to work with an independent PSAO. Around 80% of independent pharmacies across the nation do choose to work with a PSAO, including around 24 in New Hampshire. Because of their limited role and affordable monthly rate, regulation by a state of a PSAO in a way that sort of is not reflecting their role or abilities could cause the PSAOs to leave that state, reducing independent pharmacies' choices and potentially impacting their ability to remain open. And HDA, we hope to work further with the committee to either remove or work on this language in regards to PSAOs, and I'm happy to answer any questions that you may have or try my best to do so, and appreciate the opportunity to be here with you today.
Any questions? Okay. So whatever your amendments that you want to suggest, we need to just go online and see what they are.
Yes, we've submitted more detailed written testimony. I actually have copies of.
Well, can you
red
just give briefly, since we all have the bill in front of us, where it is that you want to change? And
Yeah.
You don't have to get too much detail, but just point it out to what they are, so we.
Sure. And we actually weren't sure, I know there's been some talk of a original filed bill and the bill as amended by
Right
the
now, we're
Senate.
dealing with the bill as we have.
Okay, so as amended by the Senate.
Correct.
Yeah, so the amendments that we're seeking, one of them is to,
Identify where it is.
oh, sure. In section 3, A, when it says PSAOs shall provide, we're looking to change that to make available. Looking to change the calendar days inclusion in that section to 5 instead of 3. In the next paragraph in section B, looking to add the word exclusively, and that kind of comes back to the conversation
So
about.
where do you want to add that word?
Yeah, sure. So when it says contracts between a pharmacy services administrative organization and a pharmacy shall not require that the pharmacy purchase any drugs and or medical devices exclusively from a specific entity.
Excuse me, could you name the line?
Oh, yes.
So that would be 29.
That's a better way to do it. 30.
Oh. Specific entity, right.
Yep.
So specific, well, exclusivity. Where was the word going to go in that sentence? Right after? Okay.
Yeah, medical devices exclusively from a specific entity.
Where'd your first change go?
The first change was in line 24 to take provide and use insert instead make available. And
Sorry, not all of us have the printed version with the numbers. Can you tell us the paragraph as well?
yes, it's section 3, paragraph A.
So it's not, 3 is, don't worry, don't use that number.
Oh,
You want
okay.
to say Roman numeral
Roman numeral
20.
20, paragraph A.
and little a, paragraph A, yeah, letter A. Correct. And then the next one was in letter B.
Yep, and then additionally in that same paragraph, switching from 3 to 5 business days for that timeline.
Back in A, yep.
Yep.
Okay. Anything else?
Yep, couple more. Really the only one left in this sort of section is in paragraph C. For those that have a paper version, it would be line 33 to remove the words and negotiate.
Okay, we don't like negotiating.
To provide administrative services to pharmacies and enter contracts with third-party payers. So removing and negotiate.
Yeah, there's an and, that's bad English. Okay, what else?
Yep. And then in the final section with the list, so essentially removing some items from this list, which would be numbers 6, 8, 9, 10, and 12.
6, 8, 9, 10, and 12.
Correct.
Okay. Well, I just personally, if nothing else, what I don't like about this whole paragraph is that it's in the Consumer Protection Act, 358, which which has something to do with consumers buying from an in-state provider, a manufacturer, a retailer. To throw this into 358A is very awkward. It is true that anybody who's regulated by the insurance company is exempt. This is a would you believe for you, that anybody who is regulated by the insurance department would be exempt from 358A, and that's the reason why they're put in here. Because if we were to pick up this language and do something with it, we would then have to go through the process of licensing your facility, your operations, and then regulating them through the insurance department to get them out of 358A, which is a whole nother can of worms that probably I'm not too excited about. So, would you believe? Any questions from committee members? We're all set?
Okay.
Thank you very much.
Thank you very much.
Having no more cards, okay, we'll close the public hearing. See, perfect timing. Yeah.
All right. All right, the House Commerce Committee will take up Senate Bill 124 relative to continuing care retirement communities. Who's first on the list? Okay, the sponsor. Senator Ricciardi. Senator Burrow. Thank you.
Good afternoon, Mr. Chair and members of the committee. For the record, my name is Max Taylor and I am the legislative aide to Senator Ricciardi. I'm here today on her behalf to introduce Senate Bill 124 FN, an important legislative effort to ensure the security, transparency, and quality of continuing care retirement communities in New Hampshire. This bill updates and strengthens regulatory frameworks to better protect senior citizens who invest their life savings in these communities, expecting reliable care and residency for the remainder of their lives. SB 124 FN expands the requirements for obtaining and maintaining a certificate of authority, enhances annual reporting obligations, and specifies detailed provisions for life care contracts, ensuring greater clarity and accountability from providers. It introduces robust escrow protections for entrance fees and clearly outlines the procedures and notices required before contract termination, safeguarding residents' financial interests. Additionally, this bill establishes a comprehensive Residents' Bill of Rights explicitly stating that the entitlements and protections for seniors residing in CCRCs. It mandates that providers notify the insurance department of any intended sale or transfer and may require a financial solvency plan, significantly reducing the risk of insolvency or bankruptcy that could devastate residents' lives. The benefits of SB 124 FN are clear and significant. By providing greater transparency, stronger financial protections, and a clear framework for resident rights and provider responsibilities, we ensure seniors in our communities can rely on a secure and stable living environment, protecting both their homes and their life savings. Senator Ricciardi urges your support for SB 124 FN to enhance protection for one of our most vulnerable populations. And with that, thank you for your time, and I'll have to have the people behind me answer the questions. Thank you.
Okay, thank you very much. Okay, first card will be DJ Betancourt, the commissioner.
Thank you, Mr. Chairman, members of the committee. DJ Betancourt, Commissioner of the New Hampshire Insurance Department. I'm joined here at the table by Steve Nottinger, who is kind of our legal jack of all trades, but he works very closely with our financial regulation unit, and he is truly our specialist on CCRCs. And by the way, Mr. Chairman, I am just thrilled to see all of the interest behind me in CCRCs. Although somehow I suspect that I should speed up my testimony to get to the main event, which is after hours.
I concur.
So very briefly, Mr. Chairman, as you and the committee know, my regulatory philosophy is that government intervention in otherwise a free market should only occur when well-defined objectives could be met. And so why, after that, is the department requesting additional oversight tools through Senate Bill 124 regarding continuing care retirement communities, otherwise known as CCRCs? There are three primary objectives of this legislation. The first is to update what is otherwise an outdated statute. The statute that is currently on the books is over 30 years old and urgently requires an update to address the evolution, challenges, and changes that have occurred with these facilities and with this industry over that time. Secondly, it is our ongoing commitment to consumer protection. As you know, our department's mission is focused on consumer protection, and we take that responsibility seriously for all consumers. But as I mentioned this morning, that mission takes on a heightened vigilance when we are talking about consumers who are potentially going to be impacted, who are in vulnerable populations. And obviously our seniors fit that definition quite closely. And so this is precisely the demographic that is involved when it comes to issues relating to CCRCs. Third, we are trying to, again, address some serious issues that we have seen in responding to financial distress of these entities. Currently, our statutory framework only alerts us to financial distress of these entities when it is escalated into a full-blown crisis. And so what it has left us in is a position where we are reactive rather than trying to be proactive. And so the tools that we have on the books at present, we have found to be insufficient. There are real, serious, current issues that we have had to confront in the past decade. My department has had to respond in that time to at least 3 CCRCs who have faced major financial crises. In the most recent instance, the CCRC only had approximately 10 days of cash on hand. And when you are talking about an entity who is in that degree of crisis, the options and the opportunities available to you to rectify that situation and to back that facility, that entity, away from the financial cliff is greatly narrowed when you're talking about something like 10 days of cash left on hand. And the consequences, should one of these facilities go insolvent, is really catastrophic, especially for those seniors who, as you heard, can lose potentially everything. And so we have brought forward again this legislation to help address some of those things, to help us be more proactive, to help us enhance consumer protection. When one of these facilities does go insolvent, we have to place them into receivership. And I will tell you that that is a bit of a harrowing experience. It is a lot of work in the first instance, but in the second, in that posture, you as commissioner and your department truly have the fate of that facility in your hands. Now, we contract, of course, with a professional receiver who has specialized in this work and does it for a living, but it is not a pleasant experience. And it's one heck of a responsibility, I guess, is the best way that I can put it. Fortunately for us, in the history that I have experienced at the department, we have been able to facilitate a successful outcome. In the 3 instances that I mentioned, we were able to pair the CCRC that was struggling with another CCRC that was financially healthier. And so those seniors were not put out. We were able to avert the worst case scenario. And so Senate Bill 124 represents as I've said, a comprehensive overhaul. It took us approximately 3 years to bring this proposal forward to you. It is not an easy statute. As you'll see, it's quite lengthy and complex. And we also wanted to ensure that we received as much input and stakeholder feedback as we possibly could. And I'm pleased to say that the product that is in front of you represents approximately 90 to 95% consensus of the CCRCs in the state. You always struggle, of course, to get to 100. One of the challenges of getting full consensus is that each of these CCRCs operates in a slightly different manner. And so we did the very, very best that we could to bring forward a proposal that was going to best suit all of their various models. And inevitably, you don't get it perfectly right. But I think this is a very, very strong proposal. Should there be a need for further tweaks or adjustments, we can certainly do that during the study committee phase of this process. But with all of that being said, I'm going to turn it over to my colleague, Mr. Nottinger, who can take you through some of the finer points of the proposal.
Good afternoon. My name is Steve Nottinger, and I'm an attorney at the Insurance Department. The most important thing in the CCRC statute before you is a provision that requires the CCRCs to report quarterly to us as to their financial strength. Right now, it's a year annual report. By having this be quarterly, we put ourselves in a position where we could act quickly. Before I took the job at the Insurance Department, I was a bankruptcy trustee for 30 years. And I can tell you the most important thing to deal with when you're dealing with insolvency is time. You have to be able to act quickly. And that's why when I was drafting this, it became really important to me that we put in a early warning system so that we have a time to do something with the CCRC that's in trouble. As the commissioner pointed out, we just dealt with a CCRC that had 10 days of cash left. I mean, that was a CCRC that was struggling for years. And it just goes to show that you need to act quickly. We got very lucky in that case, that there was a buyer who was willing to assume all the CCRC obligations. That didn't have to occur. It could have been a disaster for the members of the CCRC. So this early warning system is the best we can do to try to have these CCRCs examined quarterly and act quickly if they are in financial distress. One of the other things we have in the statute is we have the birth of a Bill of Rights for the residents. And what the Bill of Rights does is it gives residents all sorts of rights to self-determination, to complain without retaliation, to be on the board of directors of the organization, to basically have the right to enjoyment of their lives. And these things, although they may seem obvious, by codifying them, we give the residents an opportunity to see in plain writing that they're not just, a member, they have significant rights as residents of the facilities. Another thing we have is this bill isn't just an attempt to regulate at an increasing level the CCRCs. We put a lot of stuff in this bill at the request of the CCRCs that gives them a little bit more of autonomy if they are performing at a high level. So if a CCRC is not violating a statute, is not violating its loan covenants, it can have more freedom in how it acts relative to the insurance department. So we wanted to make sure that you all understand this isn't just a knee-jerk reaction, increasing regulation. This is really an opportunity to reduce the amount of oversight if an enterprise is performing above certain benchmarks. So we wanted to make sure that the CCRCs weren't overly burdened by this legislation. Finally, we put in the legislation another early warning system. If the CCRC is in trouble, they have to produce a financial plan within 60 days, and we can either approve or reject the plan. It forces them to act, because one thing we've learned in dealing with these CCRCs is they get overwhelmed with their insolvency situation, and they can't act, and they delay and they hide, and things just get worse. So this provision allows us to review early on in a difficult situation the financial plan of the CCRC. So those are some of the highlights, if you will, of the CCRC bill, and I'll stop at this point.
So thank you, Mr. Chairman. Just to conclude, I think Mr. Nottinger made a key point there, which is the legislation seeks to strike a balance. We need greater oversight tools for those CCRCs that are struggling financially. But on the other hand, those CCRCs who are functioning well and who are in good financial condition don't need to be subject to the same protections. And so the proposal before you acknowledges that fact And it stipulates that if the CCRC is able to meet specific occupancy benchmarks and complies with its loan covenants and other statutory requirements, it will not need to escrow its entry or waiting list fees. And so that's one example of the balance that I think Mr. Nottinger was referring to there. And obviously, conversely, if the CCRC fails to meet those benchmarks, they'll have to do that escrowing. And again, they'll be subject to greater information sharing and oversight from the department. So we really have tried to craft this proposal very carefully. As Mr. Nottinger said, not regulation for regulation's sake, but a pragmatic, narrowly defined, targeted solution to a very significant problem that the department has had to deal with over the course of the last several years. So with that said, Mr. Chairman, happy to take questions.
Thank you, Commissioner. Yes, Representative Spear.
Thank you. Having worked with you folks now for the last 3 years, I guess, I'm pretty impressed with the work products that you develop.
Thank you.
But I am curious, and there's no way I have enough information in my head to be able to judge whether or not this is the perfect answer. But you mentioned that not everybody was on board with it. Could you describe what some of the things were that they were kind of complaining about?
Well, I don't know that everybody, I think, and I guess we'll find out soon enough, there are certain provisions within the bill, I think, that may not work perfectly for every CCRC. Now, whether or not those concerns rise to the level where they'll take a formal position in opposition, I don't know. That has not been the case, at least to my knowledge, as of yet. But what I wanted to point out to you was that not every CCRC is the same. They're not all operating the same way. They don't all have the same model. But as I mentioned, we did try to do was work with all of them and try to get this proposal into that sweet spot where, while it's not going to be perfect for every single one of them given their model, it's also not going to blow up their world either and substantially harm their ability to do business and to ultimately offer these opportunities to seniors in our state. Steve, is there anything you want to add to that?
Just that the process that we went through with industry went very well. We met several times. We incorporated many of their comments. And as of this point, I'm not sure if there is an objection. I don't know. It wasn't communicated to me. I think there's a lot of support for this right now.
Thank you. Any other comments, requests, anything? Thank you, Commissioner.
Thank you very much.
Next up, I have Lisa Henderson from Leading Age. Thank you.
Good afternoon. I'm Lisa Henderson. I'm the Executive Director of Leading Age Maine and New Hampshire, based in Durham, New Hampshire. We are part of a national association, Leading Age, that operates in 36 state associations covering 41 states. And the membership is a big tent organization spanning the continuum of care, everything from home and community-based services to independent senior living, assisted living, nursing care, and continuing care retirement communities that in most cases is all of those levels of care on one campus. We represent all 14 of the New Hampshire CCRCs, all of which are not-for-profit organizations. And the department very much had an open door policy to speak to us about their desire to both modernize the statute as well as put in that early warning system. And, our members, to be clear, the vast majority are in outstanding financial health, and they're proud of that. And therefore, we're happy to submit to increased reporting, and do appreciate that on one particular point that the Commissioner and Mr. Nottinger were referencing around escrowing entrance fees, that looking at a measure of occupancy and days cash on hand as a means to get an out from that requirement. Escrowing can be difficult with banks these days. They're not very interested in doing that. And so we appreciate that consideration, because what that's saying is when you have proven through high occupancy and a strong cash position that you can weather storms, then you are not needing to take those additional steps of escrowing that are more of an administrative burden than anything, but the resident's investment is most assuredly secure. So I don't have anything in particular today to bring forward that seeks to further modify this. The department has been very open to our concerns. Perhaps to your question about, what were the range of concerns, I'll say that it's possible that there may be a subset of the group of 14 that, because they operate differently, and let me shed some light on maybe what that means, may feel like this is a lot of administrative burden for them. And that is because, as I say, in the traditional model of a continuing care retirement community, you'd have all those levels of care because you're in effect entering into a contract for prepaid health care. You are getting the promise that you will be cared for through to end of life. Now, the contracts can vary, and the degree to which the financial requirements in terms of a monthly service fee could be structured differently depending on how much your upfront entrance fee is. But there are 2 communities that are just at this time independent living only, and one that was independent living and assisted living. And so they didn't have nursing care, and they didn't, or as I say, in one case, assisted living. So they didn't have the promise of future care. They are exempted, thankfully, from having to do actuarial reports, because that would be to determine can you deliver on a promise of care, and they're saying we don't. But they are regulated in this because they take entrance fees over $10,000. So that is the threshold that got them sort of lumped in and defined as a CCRC, but in the sense of not really being not structuring their contracts in such a way that is this promise of care to end of life. They're different, and they're a lot smaller as well. So with size, and you look at what do I need to comply with and the resources that you have, it's just a little more burdensome for them to submit that reporting. But I don't think it's for reasons of financial concerns about what they would have to report.
Okay, thank you. Anyone else? Any comments? Thank you, Ms. Henderson. Anyone else have a pink sheet in on this one? If not, we're going to close the hearing on SB 124. Okay. Guessing. Yeah. All right. Being as it's 1:30-ish, we are opening the hearing on Senate Bill 297 relative to pooled risk management programs. Yeah, I know. Okay. Okay. The prime sponsor is Senator Carson's representative. So, let's do it.
Thank you, Mr. Chairman, members of the committee. Good to be back before Commerce. I am Grant Bossy, Deputy Chief of Staff with the New Hampshire Senate, here to introduce Senate Bill 297 on behalf of Senate President Sharon Carson, the bill's prime sponsor. This bill was filed at the request of the Secretary of State because of financial and operational issues potentially challenging the solvency of some of the risk pools operating in New Hampshire. Pooled risk management programs were authorized legislatively in 1987 to allow for political subdivisions to come together to self-insure coverage for their employees and municipal property, such as health, property casualty, and workers' compensation. However, the Secretary of State is concerned that some risk pools have set rates far too low to cover their liabilities, threatening the solvency of the risk pools. This would leave local taxpayers on the hook. This bill sets minimums and maximums for contingency reserve, ensuring the pool's success as an ongoing entity, while making sure surpluses that are not needed are returned to the pool member political subdivision and eventually to taxpayers. It also adds emergency trigger mechanisms that authorize the Secretary of State to seek a receiver through the court to enforce an immediate assessment of contributions to ensure financial stability and protect New Hampshire taxpayers, as well as active and retired employees. The legislation increases transparency through requiring disclaimer language for the self-insured coverage lines and states these pools are member-owned. The Secretary of State's office is working with stakeholders on an amendment that I believe will be brought forward today that hopefully will protect taxpayers from short-term premium increases and the long-term risk of insolvency. I would defer questions to the Secretary of State's office. If you have questions specifically for Senator Carson, I'll make sure you get an answer. Senator Carson thanks you for your consideration and support of SB 297. Thank you.
Any questions in the committee? Seeing none, thank you very much.
Thank you.
The chair will call on David Scanlon, Secretary of State. We didn't get a card yet.
Oh, it must be in there somewhere.
Okay, well, why don't you come in and testify and we'll worry about a card later.
My name is James Gray. I represent Senate District 6, which starts up in Alton and Gilmanton and comes down Route 11 to Rochester and Stratford. Senate Bill 297 has been a thorn in my side ever since I first saw it. Okay? The first thing I did is try to understand what was going on. I went back to the charts that were giving me. I went back to the Health Trust minutes of their board meetings. I went back to the actuary reports. And I now analyzed the thing as best I could. That there's a couple of significant things that happen. Because of COVID, there was, I'll call it underutilization of the insurance. People weren't getting the colonoscopies. People weren't getting the mammograms. People weren't getting, and you go on with whatever you can come up with. And because of the way the law was at that time, that forced, or that increased the reserves that all of the risk pools had. But there was also a demand there. So come along 2023, that demand hits. And significant decreases in their retained dollars caused them to be much, much smaller. The actuary's report that was provided, and Milliman is their actuary, provided two different scenarios. They said if you want to get back to no greater than a 5% chance of insolvency in 1 year, then it's $90,000, and to get there in 1 year, when you actually do the calculation, it would have come out to a percentage of 6-7%. You know, that was not, number was not in the actuary report, but was in one of the board meeting report. They gave an option B. And if you want to get there in several years, then you use $100 and whatever million as your goal, and you use a different percentage. My analysis says that Health Trust picked the low dollar figure, but they did not pick a percentage that would get them there in the time period that the actuator identified in their report. So they picked one from column A and one from column B, and that's not what you should have done. You should have picked either column A, column B, or as they did in 2024, because they did much better in 24, looking at what their actuary told them to do, is they picked a higher goal, and they picked a higher percentage that will get them there in a couple of years. Is 5% the, chance of insolvency the right thing? I can't tell you that. That's what actuaries are for. Okay? But I can tell you that's what their actuary was tasked to do, is to, if I'm going to have a 5% chance of insolvency, how do I get there? And in my opinion, they did not follow that in 23. They did much, much better in 24. Are they at immediate risk of becoming insolvent today? No. But they're nowhere near that 5% that they asked the actuary to do the calculations on. So we took the testimony that we got in the original hearing. We were told that the individual towns said, well, gee, if we have this assessment, we don't have any way to get the money. So we took that back and we said, okay, how can we get them the money? And we added to the bill this 4% fund that would be set up in accordance with the DRA recommendations. And we said, you can do it over 4 years. So 1% this year, 2% the next year, 3%, and 4% till you get to the total. Okay. Somebody said, well, gee, what if I could get insurance? I said, it was good for me. Go see the Secretary of State. What if I can? And pretty much a lot of the things that they've asked, we said, okay, well, let's find a way to go do it. And right now, as was spoken by the previous speaker, there is an amendment out there, I believe, I have not seen it yet, that says, well, what if we don't keep that money down at the local level, down at the town, the city level? What if we keep it at the health trust level? And I'm told the Secretary of State said okay to that too. Am I in favor of the suggestions that I've heard of moving it to the insurance department? No, I am not. Absolutely not. Until this problem is solved, until they become much, much closer to their 5% solvency or chance of insolvency. And I'll be happy to answer questions.
So, as a believer that it should have been insurance way back when, many, many, many moons ago, I voted against the midnight regulations that were placed on it in 2010. My question to you is, to say that you don't think it should go to the insurance department, does that mean we have to wait 5 years, that you have to get all these percentages, all these years that you want all this money added back up? Is that what you're saying, is that you want to wait 5 years before it moves over to the insurance
I think
department?
the chairman and I had a discussion out in the hall, and I will relate the same things I told him out there, is that I am willing to entertain a bill in the next session that would move them. But I do not believe that it is wise or prudent to move them until we get them to a level that they are solvent.
So we have a chicken and the egg problem.
Yes, sir. I don't know whether you're the chicken and I'm the egg or vice versa.
I guess the issue of being is trying to figure out what is the right methodology to get to solvency. Has always been, in my understanding of the insurance department, and I've been around a couple of years, has always been that that's something that the insurance department works out with the entity, with the threat of maintaining their license and let them to continue to operate. But the idea of doing it statutorily and putting it in law has only been a concept that I've heard from the Secretary of State's office, because they don't do rules. And I never understood that way back when I first heard that. It
Mr.
still
Chair,
doesn't
is
make
there a
sense to me.
question? Is there a question there?
My question is simply, how does it make any sense that we put in statute what numbers they have to run as threshold numbers, when that, if at the end of the day, it should be run by a department that does know about solvency, doesn't do it that way?
I'm certainly willing to do more if we can get the two actuaries to actually to talk about this issue. Do I think they need to get to that 5%? Probably not before we have additional conversations. But do they need to get closer than they are right now. I would advise you that you might be able to get a better, when Health Trust comes up to testify, ask them what their percentage chance of becoming insolvent is right now compared to what the actuaries did their calculations at.
Fair enough. If you don't have any questions, Representative Gibbs has a question.
Thank you, Mr. Chair. And thank you for coming to testify and answer our questions. You said that you want to get these entities to a place where their chance of insolvency is 5%. What I wanted to ask about is what their current chance of insolvency is. And did I understand you correctly that we need to ask that question of somebody else?
I do not have the information. I'm not an actuary. I know what the totals are. I would imagine it's not a linear function, but at least a function of a square, that would be like an exponent where it would increase greatly as you get up to this number or that number. But there are actuaries behind me that may be able to answer that. My layman's, review of this would say that they're nowhere near the 5%, and the 5% is what was in their actuary's report about what their actuary wanted them to be at.
Thank you.
Thank you very much. Is there any other senator or representative who would like to testify? Seeing none. Okay, we'll move on to Dave now. In terms of, I have 4 cards from Secretary.
I'd like my team to join me.
And we all.
Thank you, Mr. Chairman and members of the committee. I'm David Scanlon, Secretary of State, and while my team is getting settled here, I'd just like to say that I know that there's been a lot of lobbying and discussions going on about this that's out there. I understand there's a lot of passion involved. I don't want to fuel any fires, so I'm going to kind of tone down my remarks to not inflame, but to try and give the committee an accurate representation of where we're at the moment. Just want to read a couple of brief sentences in the risk pool statute. A pooled risk organization is an ability for political subdivisions to join together to self-insure for either health insurance or property liability, things like that. The state of New Hampshire does that with its health insurance plan. The city of Manchester does it. The city of Nashua does it. Those are all political subdivisions that are large enough to have the scale to be able to do that effectively. What RSA 5B does is it allows other political subdivisions that do not have that size to be able to join together to create that size that's large enough so that they can fulfill the same function for local employees. So in RSA 5:B, the sentence says, to accomplish the purposes of this chapter, 2 or more political subdivisions may form an association under the laws of this state or affirm an existing association so formed to develop and administer a risk management program having as its purposes reducing the risk of its members, safety engineering, distributing, sharing, and pooling risks, acquiring insurance, excess loss insurance or reinsurance, and processing, paying, and defending claims against the members of such association. There are 4 current entities that fit that bill. Health Trust is the largest one. There's Primex, there is School Care, and there's New Hampshire Interlocal Trust, NHIT. The law goes on to say in 5B6, any pooled risk management program meeting the standards required under this chapter is not an insurance company, reciprocal insurer, or insurer under the laws of the state. An administration of any activities of the plan shall not constitute doing an insurance business for purposes of regulation or taxation. These organizations have an exemption from having to file anything with the IRS. And then 5B:4-A gives the Secretary of State the responsibility to oversee this provision. I inherited this statute, so it's, I know that there's some discussion about moving, who would oversee pooled risk organizations. I'm certainly open to that discussion. However, for reasons that hopefully you'll understand in my testimony now, I don't believe is the right time to do that. So just a brief history of the events that led up to the filing of Senate Bill 297. Back in 2023, Health Trust came into my office and self-reported that there were financial concerns about the level of reserves that they had on hand to be able to pay their claims. And we, my office, Bureau of Securities, which is charged with, looking into the details, made attempts to look into it. They tried to gather information. There was not the degree of cooperation that there should have been in making that happen. But through the process of trying to understand where we were at and bringing actuaries on board to help us make certain determinations, we became aware that this was not a situation that was unique to just Health Trust, but there was another pooled risk organization, New Hampshire Interlocal Trust, that was also having financial concerns. The two other organizations, Primex and School Care, were running in a sound way, and so we did not have that level of concerns with those organizations. As time went on, it became more and more difficult to try and get the information that we needed to make accurate assessments to try and help address the situation, to the point that risk pools were hiring money for lawyers and now lobbyists. And the state of New Hampshire, as a result, through my office, was also having to spend money on attorneys and experts sitting next to me. And it was reminiscent of litigation in the past 10 years ago and 10 years ago before that, where significant sums of money were spent to try and battle these issues out in court. I didn't want a repeat of that because it's a waste of taxpayer money. So I went to our legislative leaders. I described the problem with them. We had a presentation with actuaries, and the Senate agreed to sponsor Senate Bill 297. Now, there's been a lot said about what 297 does out there, and I would like to make clear just exactly what Senate Bill 297 does. It creates a low range and a high range of where reserves should be kept to maintain a healthy risk pool reserve fund. It has a warning system that if those reserves, and the range for those reserves is set at 12% of estimated claims on the low end, 16% on the high end. If the amount of those reserves drops down to an 8% level, then alarm bells start to go off. And if it drops down to a 4% level, then there's a requirement that assessments be made on the political subdivisions that are in that risk pool to raise the level of reserves up to a healthy place. That's it. This does nothing, the bill does nothing that interferes with the management of a pooled risk organization. It does not tell what plans a pooled risk organization has to offer. It does not direct them not to get involved in prescription drugs or wellness programs or other things related to the health and the benefit of their employees. It simply creates parameters within which reserves need to be kept to maintain a healthy organization. Senator Gray proposed an amendment related to making the assessments if the reserves drop down to that critical level. And it was designed to be at the local level, which would have been a way for the communities to hold on to their money and manage it, and then have a sum on hand that they could pay the assessment so they wouldn't have to make mid-year adjustments in their budgets. After going out and speaking with some of the board members of the pooled risk organizations, I came to the understanding that that record keeping at the level at the local level would be challenging and difficult and a fairly large project. So in order to address that, we decided instead of having that assessment fund kept at the local level, that we would have it kept at the pooled risk, within the pooled risk organization. That fund would be there and would only be tapped if the level of reserves dropped down to the point that an assessment had to be made. That's what the bill does. What the bill does not do is create a different way that risk pools have to operate. It doesn't do anything, as I mentioned, related to the management of the organization, products that they can offer, as long as they're related to the purpose of 5B. I will say that after, as this process has developed, NHIT announced to their members, their political subdivisions, just over a week ago, that they were closing up shop. And given the circumstances that surrounded how that happened, I requested a receivership from the court, which was granted, so that we are going to make sure that that organization runs out in the best interests of the member programs. But that event certainly validates the concern that we raised early on and that we're trying to address with this piece of legislation. I have been working hard to build trust and cooperation between my office as the regulator and the pooled risk organizations. And I have been willing, and I have gone out and had conversations with the pooled risk organizations, the members of those organizations, employees, unions, anybody that's willing to have a conversation. I've gone in and I've answered their questions. I did the same thing with Health Trust a week ago. I will say that the questioning that took place during that event was more like a deposition than an open conversation. I did not have the benefit of counsel to help me prepare or answer those questions. I'm a layman, and so I answered them to the best of my ability. I might expect that later on you might hear about things that I said. Those things were said in the spirit of cooperation, and I want to try and build that trust back. Anyway, I'm going to stop there. I'd be happy to answer questions if you have any, but I'm going to turn this over to Karina Ferrari, who's been acting as an attorney on this. And then we have two actuaries here, Wal Lee from Casco, and Matt Noonan from Siegel. And Mark, I'm sorry. And Siegel is the same firm that does the actuary work for the state of New Hampshire. Christina?
Yes, sorry. Don't
That's
mean
right.
to crowd
No,
you.
no.
Bear with me. Thank you. Good afternoon, Mr. Chairman and esteemed members of the committee. Just for the record, my name is Christina Ferrari. I am the outside counsel to the Secretary of State's office in the Bureau of Securities Regulation with respect to public entity pooled risk management programs and enforcement of RSA 5B with respect to such programs. I will try my best not to repeat the remarks that have already been made today, although I certainly agree with them. As you may know, and as you've heard, public entity pooled risk management programs are unique creatures by statute. These are not insurance companies. That's recognized not only in RSA 5B, but also in the tax code and in various court decisions here in New Hampshire. These are member-owned, member-governed, and member-driven. The net assets of the program are the property of the members. These are quasi-governmental in that they perform an essential government function for the political subdivisions that belong to them. These are solely funded by public monies that are contributed by the political subdivision members to self-insure and to pool or share their risks with each other. In other words, it's like group self-insurance. RSA 5B sets out certain requirements for the formation and the governance and the operation that must be met by these programs. One of those requirements, in fact, the most critical requirement, I would say, is the mandate that all earnings and surplus in excess of any amounts that are required for administration, claims, the purchase of excess insurance, and reserves be returned to the political subdivision members. This is a unique aspect to RSA 5B in New Hampshire that isn't in other statutes regarding pooled risk management programs in other states. The Supreme Court decision in 2014, the appeal after the LGC administrative order came down in 2012, recognized this mandate and said that all operational decisions must be made through the lens of returning surplus. As was referred to earlier, in recent years, pooled risk management programs in New Hampshire have experienced unprecedented losses of millions and in some cases tens of millions of dollars of public funds. These pose significant risk to participating political subdivisions who largely self-insure through the programs and will ultimately be responsible for any unpaid liabilities such as claims and expenses and other losses. As to what we understand has caused and contributed to the financial difficulties and the loss and deterioration of financial footing for some pools, you'll hear about that in more detail with the actuaries who have that experience and can give you that. But however, based on what we have seen thus far, and what we have learned about the operational decisions and other factors that have caused or contributed to these financial difficulties, additional reasonable guardrails are needed in 5B. This will not only stop the downward trajectory that has already occurred, but will prevent it from reoccurring in the future. SB 297 and the proposed amendment that's introduced today provide those reasonable guardrails. They fully protect against the risk of insolvency, and that's their main purpose. They promote transparency, and they further the public benefit purpose of these programs. These guardrails are designed to be as minimally invasive as possible, as you heard from Secretary Scanlon. They are limited to the specific areas that we believe will have the most positive impact, while at the same time preserving local control and being flexible enough for these to remain member governed. In order to give you more details, I'm going to run through those for you. SB 297 adds 5 defined terms for clarity and additional guidance. 3 of those are for terms that are already in RSA 5B. There's 1 new definition for a new term for assessments, and through the most recent proposed amendment today, 1 new definition for a new term, which is restricted fund balance. There's the addition of language making it clear and explicit that each pooled risk management program is member-owned and that the governing body of that program has a fiduciary responsibility to its members and must act with certain standards of care. Depending on the legal structure that these programs have, those duties are already there, but this makes it more explicit so there is education, accountability, and transparency. In a similar vein, this newly requires a program to make certain public and conspicuous disclosures to actual and prospective members, again, for education, planning, and transparency and accountability. Most importantly, it adds tools to guard against the risk of insolvency and impaired financial footing. It gives language that addresses what happens in the event there is financial impairment, sets out certain steps to be taken to help put the pools on a better path without significant delay. Includes written notification to members of a potential assessment, a written proposed course of action, And it gives the Secretary of State authority that can be used, if needed, to issue an order to a governing board requiring that certain deficiencies be abated. And if those orders do not be put into place by the governing order within certain timeframes, it gives the Secretary of State the authority to go to the court and seek either an order requiring the board to abate those deficiencies or seeking receivership over that entity, depending on the circumstances. And finally, assessment of each member on a pro rata basis to satisfy the deficiency if needed. On the assessment piece, which is of much debate, this provides for a prompt assessment of a participating member if required, if after the annual actuarial evaluation of the contributions and assessments necessary and the reserves necessary finds that there's not enough. Regarding how the assessments will be paid, if, for example, assessments are necessary in the middle of a fiscal year. In the most recent proposed amendment today, those assessments are one funding mechanism for those assessments, if a pool decides to do so, is to set aside up to 4% of the previous fiscal year's contributions from an earning and surplus that is defined at the end of the year. Set those aside in a restricted fund balance so that those monies will be used before members are assessed in case an assessment is actually needed. As we'll get into more of our consulting actuaries, it sets forth minimum and maximum ranges for a contingency reserve, depending on which line of coverage are involved. Provides for a contingency reserve replenishment added to the next calculation of annual member contributions. It provides for a holding of a hearing by July 1st, 2027, and every 4 years after that, with the Secretary of State's office and all pool risk management programs to take a look at the contingency reserve rate changes and the reserve amounts in terms of the maximum and minimum range. It also gives the board of directors of these programs, with a vote of the board and notice to members, the ability to make a request to the Secretary of State for a 1-year increase to the maximum level of the contingency reserve based on audit information and actuarial analysis. I'm going to let the actuaries fill you in on more of the details in terms of the actuarial analysis in the bill, but I will remain available to answer any questions you have about the language.
You willing to take a question? We do have a question. Representative Spear, you may inquire.
Thank you. My question is really two things. Coming from a point of view of insurance, because that's what we typically work on. What I see is a risk pool, like an ERISA plan, self-insured plan, that is putting the risk onto the towns rather than keeping the risk themselves. And I also see this notion of returning excess money to the town before the pool knows if it needs it or not for the future. So the whole setup seems kind of odd to me. How do you maintain a risk pool, not putting it onto the town, and at the same time, how do you decide to give money back when you don't even know what you're going to need the next year? Can you explain why it was set up in such a apparently strange way?
Well, first, Representative, thank you for your question. When RSA 5B first came into being, I believe it was in 1987, it recognized the ability for 2 or more political subdivisions to join together and self-insure. And with self-insurance, you have a situation where the risk always remains with those political subdivisions. It doesn't transfer to the pool entity itself. It's really a sharing of risk right from the get-go. And so it's always been designed that way, and it always should function that way. And that aspect is not unique to RSA 5B or New Hampshire, but that is an aspect that is part of public entity risk pool programs in all the states that have them and operate that way. And so instead of having transfer of risk that goes straight to an insurance company like you would see in the for-profit world, where you pay one rate and no matter what happens, you're not going to pay any more. The sole source of funding for these types of programs, because they're self-insurance, where you are sharing your risk, is coming straight from and always from the political subdivisions. So regardless of their losses that may happen, the funds that are going to pay for those, whether they're coming from rates of contributions that are being paid or from reserves that are existing, it's always going to be public money that comes from political subdivisions. So it really is that group self-insurance or that sharing of risk through the self-insurance in that way. Your second question it took me a lot of time to figure this out, and thankfully had the benefit of our actuaries to teach me about this as someone who's not an actuary. But to answer your question, is about timing. So at the end of the fiscal year, let's say that's June 30 of a particular year. So this year it'd be June 30 of 2025. There is, from that point onward for, I think it takes probably a couple months, a few months, maybe 2 or 3, to figure out what actually is needed for the upcoming year. So what has been used for the past fiscal year in terms of claims, administration, reserves that were set previously, any reinsurance that may be purchased, and then do we need more reserves, for example, in the upcoming fiscal year? Those decisions are looked at and made before, for example, a pool risk management program would declare a surplus. So there is time in that time frame where those questions are answered. So it's not going to be a situation where you're moving forward not knowing what you need in the future and then either not having enough or having too much. That is really the time where those analyses are made and those decisions are made.
Thank you.
Representative McKay?
Thank you. Thank you, and thank you for taking my question. And possibly this is a question maybe for one of the actuaries, but I got a letter the other day, an email, and after reading it, I thought it was from Chicken Little and the sky's falling in. It was from a smaller municipality that believes that this bill is an absolute disaster, that they're going to get raked through the coals and having to come up with some more money. Is that an over panic, so to speak?
Good afternoon, Mr. Chairman and committee members. I'm Hua Li, one of the actuaries working with Casco, one of the 5 accredited actuaries that's been working with the Secretary of State. I decided to take this question because there's a very straightforward answer to your question. If you turn to the very last page in the package that's been provided to you, analysis has been performed for each of the, it was for now 3 remaining risk pools of what the impact of this bill would be on their contributions if claims experience is as the risk pools expect. The only one shown here is Health Trust, because our understanding is that they are the only one that is not yet fully on board with the bill. The others are. The analysis shows that should the experience be similar to what Health Trust is expecting, the contributions of their members will actually be slightly less over the next few years than without the bill. And then the impact for the other 2 risk pools, Primex and School Care, should the experience be close to expected, is 0. No difference in the contributions. I believe potentially what might have led to some of the concern, without obviously reading the letter, is the amendment that the Secretary of State has just introduced right now. It changed the special restricted fund for helping to fund potential assessments, even though those assessments are highly unlikely. Originally, they were going to be held by the members, and the members would have to fund them. That is now changed. They're going to be held by the risk pools, and the risk pools will fund them using excess reserves. So I hope that answers your question.
Thank you very much.
Okay, proceed.
Do you want to present?
Yes. Thank you. Having already made the introductions, one of the main reasons that you're here listening to this proposed Senate bill is that there used to be 5 risk pools in New Hampshire. Okay, and then 10 years ago, when my company was brought on to help manage the insolvency and runoff of PLT. Okay, so then it was down to 4. Earlier this month, the NHIT announced that they were going out of business. At the time of the announcement, they had $1 million more in liabilities than assets. So they've gone insolvent. Resolving them is going to be a nightmare. So, whilst I enjoy working with the Secretary of State's office, I don't want to be brought in again in another 10 years talking about another risk pool insolvency. You've gone from 3 to 5. Okay, so when we looked at PLT 10 years ago, we found the primary driver of their, insolvency, running out of money, so they were charging significantly less than the actuarially recommended contributions. They were being supported by an illegal subsidy, and when that was forced to end, they could not dig themselves out of charging so much less than the actuaries were recommended. NHIT, when we were brought on to look at the Senate bill several months ago, we started looking at them immediately and noticed they are not even calculating actually recommended contributions regularly, let alone charging it. On the rare occasions they hadn't actually look at their contributions, they were collecting significantly less than the actually recommended contributions. In both PLT's case and NHIT's case, they were doing this openly. They were not. This was stated in the minutes to compete for market share. They're deliberately charging much less than actually recommended to compete for market share. It led both of them to insolvency. As the Secretary stated, Health Trust self-reported to the regulator about 2 years ago that they were in significant financial trouble. At one point, I believe they had less than 20 days of reserves left. So when we were asked to come in and do an examination, we found that they were consistently charging less than actually recommended contributions in order to compete for market share. The meeting minutes showed at least 8 or 9 instances of this. For example, Senator Gray talked about how the end of the pandemic, people started coming back to the doctor again. Well, their actuaries warned them about this, recommended adding a charge. They voted not to add this charge. But there's 8 or 9 different instances of this. So currently there is no regulatory protection against insolvency at all. And there is essentially no real regulatory tools to make any of these risk pools charge actuarially recommended contributions. We've tried going in and kind of speaking with them, particularly Health Trust, since they basically asked us to come in. We make recommendations on how you can do this. Maybe out of every 3 recommendations, they might do 1. But essentially, there's no real tools currently to at all to protect against insolvency and to make people charge actually recommended contributions. This Senate bill achieves that. Okay. Unfortunately, it's not passed soon enough to prevent the insolvency of NHIT. However, as I said, they have currently significantly more liabilities than assets, and they are going to need to be wound up. One of the measures in the bill will give them the authority to assess members for that deficit. Okay. Without that authority, resolving that deficit, if it's still there when they stop collecting their last premium, will be an absolute mess. Without the authority to assess, that deficit, it's going to fall on whichever poor political subdivision or department happened to have the employees who incurred these medical bills. They're already owed to the healthcare providers. That's what this deficit means. It could be hundreds of thousands of dollars. They're going to have to figure out how to come up with that money. Okay, and so even though we couldn't prevent the insolvency in NHIT, this bill is actually more needed than ever now, because there's a provision in there that will help NHIT wind up in an orderly fashion. So literally, if this bill were to pass, within weeks, the provisions will be used to make sure NHIT's insolvency and runoff is not a complete mess. I will stop for a minute. Mark Noonan will discuss the 2 key provisions that are contained within the actual bill.
Good afternoon. My name is Mark Noonan, or Matt. I will respond to both. I do work for Siegel, and for transparency, as was mentioned, Siegel does also work with the state health plan. I myself do not work with the state at all. It's in a totally different section of Siegel. Again, I work with the BSR. I've been working with them for about 5 years now. And again, no one on the state team works on the BSR team, and no one on the BSR team works on the state team, just to put that out there. So I am going to be going over some stuff. There might be some overlap. I will try to keep it to a minimum. A lot of what you've been hearing today is around solvency protection, and more specifically contingency reserves to help with that solvency protection. Just to take a step back for a minute, annually pools need to set contributions for the year. During that contribution setting process, you're starting with paid claims, adding in administration, and then also factoring in any other adjustments that may be necessary. Some examples of those adjustments would be if there's plan changes, if there's known high-cost services that are going to be happening, like, for example, the weight loss drugs that everyone's talking about, or if there is the need for any makeup for prior contribution deficiencies. Well, I'll get into more of that in a minute here. The main point is when setting the contributions for the following year, all of those factors should be taken into consideration. I think there's going to be higher claims, higher trend, or if you know that there was a contribution deficiency, all of that should be accounted for in the contribution setting process. So in theory, at the end of the following year, contributions are paying for claims dollar for dollar. Now, of course, in reality, that never happens. You're going to have certain years contributions higher than claims, other years claims greater than contributions. Now, in the extreme case, you have the situation where the claims, far exceed contributions to the extent that the pool becomes insolvent. And that brings us, back to this whole concept of contingency reserves. Contingency reserves are a critical and necessary thing for the pools to have. And when it comes to contingency reserves, they are basically intended to account for some things that, pools have no control over. For example, if there's $1 million claim for a transplant or a neonate event, or if claims just for whatever reason that year are, much greater than expected, those are somewhat out of the control. There are other reasons, however, that are more self-inflicted, I'll say, and those are some of the things that have been discussed already as far as not setting the contributions to the recommendations by the actuaries. So SB 297 is intended to address the contingencies, the contingency reserves. Now, somewhat to address your question, in theory, you could keep unlimited reserves and never have, an issue with insolvency, but that's not really a realistic scenario. So then the question becomes where to set that level. As mentioned, SB 297 sets the health target at 12 to 16% of claims and administration costs. For property and casualty, it's a different percentage. It's 30 to 40%. As a general statement, health claims, get incurred, processed, and paid much quicker than property casualty claims. Since there's a shorter time frame, the contingency reserves are less on health than property and casualty. Just to avoid confusion going forward, I'm just going to be speaking to the health sides and not try and, go back and forth with different percentages. So as was mentioned, for health, it is 12 to 16%. And that equates to about a month and a half to 2 months of claims experience. And then in addition, SB 297 also allows for the pools to request an additional 2%, so the maximum will go up to 18%. However, that 2% would need to be submitted, with support. It would go to the secretary, and then that, request would either be, accepted or denied. But getting back to why 12 to 16, or again, potentially 18%. For health claims, medical claims are paid, most medical claims are usually paid within a month or two from when they occur. Pharmacy claims are essentially paid immediately. Pharmacy claims are paid within a week. So what all that equates to, at a contingency reserve at 16%, a pool would have enough reserves to pay for 2 full months of claims, even if there were no additional contributions coming in month to month. Now, of course, there will be contributions coming in month to month, so that kind of bare minimum 2-month time frame is really expanded to a much longer period. In addition, as I mentioned before, the contributions are updated annually, so that to the extent that in any given month there was some material event that happened that kind of ate into the contingency reserve, that risk can be addressed relatively quickly with higher contributions going in the following year. So basically, with the rate setting process, being able to quickly address deficiencies in the following year, and the fact that at 16%, the contingency reserve will allow for, again, at a bare minimum, 2 months, and most likely much greater than 2 months, the risk of becoming insolvent with a 16% contingency reserve is minimal. Now, what occurs today without SB 297 in that contingency range of 12 to 16% is that in many instances for pools that are on the lower end of the contingency reserve, it's because of those self-inflicted decisions that are made. So it is more due to prior year rating deficiencies. And again, as mentioned, those could be, not recognizing trends that are occurring. It could be not offering the actuarially recommended rate levels, or could be capping rate increases to try and maintain market share. But over time, these continued contribution deficiencies have a compounding effect. And this is where contingencies reserve have the potential of being misused. The contingency reserve, again, is intended to be used in a given year for the unexpected costs in that year. Reserves are not intended to be somewhat of a security blanket where plan designs or contribution decisions made are the aggressive nature and are most likely going to end up in resulting in a contribution deficiency. But all of a sudden, this decision becomes easier if you have contingency reserves that are greater than otherwise needed. So SB 297, the intent of this is to minimize that risk. By having the contingency reserve target of 12 to 16, once pools are within that range, they are encouraged to set premiums such that they'll stay within that range. Meaning if they do fall below 12%, the following year they are required to get back up to that 12%. There's no kicking the can down the road of, well, I'll do half this year and half next year, or I'll do a third, and a third, anything like that. There will always be good years and bad years, but from a solvency perspective, a pool with a bad year at 16 or even 12% is going to be in much better shape than a pool that is sitting at 8%. And just to follow up a little bit on the 4%, risk fund that's been talked about. Again, that is a fund that is going to be going into a totally separate account. It is not associated in any way with the contingency reserve. It's more of a break the glass in case of an emergency fund. And again, the pools have the options to either fund that additional 4% or not. But SB 297 does allow them the flexibility to make that decision. Again, they can fund it, they can not fund it, and then to the extent that it is funded, in the unlikely event that they run out of reserves, it can be pulled from that account, and the individual member groups would not need to be directly assessed. Yes?
Representative Spear.
Thank you. We're talking about 12%, 16%, 4%. And one of the things we've seen is very problematic is when you put into law a percent that may not work 5 years from now. How do we address that? Are we going to keep changing this law as things change in the universe?
In the law, it does state that 4 years from now, it will be relooked at and reassessed.
Did you say 4 years?
4 years. Is it working? Is it not working? If it's working, great. If it's not working, what needs to be done to make it work?
Representative Ammon.
Thank you, Mr. Chair. Thank you for your testimony. Lots of detail. I'm still trying to process it.
Sorry.
It's okay. Could you paint a picture? What is the risk of doing nothing? Could you paint a picture of, what happens if we let this go until it's too late?
The risk of doing nothing is NHIT. That's basically the risk of doing nothing.
Say it again.
It is NHIT.
Having going bankrupt.
Yes.
And putting into receivership.
Yes.
And dissolving.
Correct.
And then what will happen? Then they would be forced to buy their health insurance from private entities, other insurance companies that are.
Or they could be in a different pool. There's additional health pools, for example, in that one that could transition those members and have comparable coverage or potentially the same coverage. I think the worst case scenario beyond having a pool like NHIT or any other pool go insolvent and have to dissolve, not only do we have an issue of members potentially facing great disruption in their benefits, and having uncertainty, potentially additional costs, we have a situation where if there are remaining claims that need to be paid or other losses or liabilities that need to be paid, those don't disappear, unfortunately. And since the only source of monies that come into these pool risk management programs come from public funds, taxpayer funds from the political subdivisions, then unfortunately, even if an entity would try to seek bankruptcy, in the end, it would go back to the political subdivisions anyway to cover those losses.
Well, so that goes right to my question. To actually implement this, aren't we now going to have to go back now to all the cities and towns and assess them now? I mean, where are they going to get the money from? I mean, you're going to say that they're already billing out enough? No, because you're putting it in a separate little fund. You're going to say, well, this is the break the glass fund. But at the end of the day, it seems to me that basically we're creating a plan to get rid of a couple of plans here and start all over from fresh.
Well, assessments are only if a contingency reserve goes down below a certain level. For example, goes down below 8% or 4%. There's different tiers. And that right now is a situation where putting aside NHIT because they've
Are they going to do an assessment? Are they going to recover their losses?
That hasn't been figured out yet because they've just made a decision to dissolve, and there needs to be a
Right. Well, I
review.
understand they dissolved. They made the decision to dissolve, but you guys made the decision to put them into bankruptcy.
No, the court has appointed an independent.
Yeah, but
third-party
you went and
receiver.
requested it from the court to do that.
Correct, but the
so you
receivership is not
basically-
bankruptcy. So the
Oh, okay.
receivership is having a professional receiver go through, get an understanding of what the assets are, what the claims are, what the plans still are in place. There are still some political subdivisions whose plan year goes until December 31st of 2025, so beyond that dissolve date, and get a handle of how to make sure that things are covered and that members are able to have not a loss in their benefits. So that still has to be done.
Right.
Get
See,
an
I guess
idea.
to answer my fellow representative's question is, what's the fiscal note of this bill to all the cities and towns and all the municipalities going forward? I mean, are they all going to have to kick in more money? Is that at the end of the day, I'm hearing they're all financially risky. I mean, Primex, that's property and casualty, so to me, they're out of the mix. This is a health insurance problem, and are we, if we pass this bill, are we now requiring a special assessment to all those municipalities and in that association? You guarantee me that there will not be a requirement that a special assessment will be required to comply with this statute.
No, not because of this bill. Right now, the condition of Health Trust is that they are well below the lower threshold of the range that we are recommending.
Okay.
It's something that I think they agree they have to build back up to. So regardless of whether this bill passes or not, there are going to be rate increases that allow them to build that reserve back up. This bill really does nothing in terms of assessing the towns or political subdivisions additional funds for anything.
So even if they ignore the statute and just go on and do what they're doing, there's no consequence?
The statute is designed to make sure that the pooled risk organizations maintain a healthy reserve level that's required in the statute.
And how's that enforced?
If in the bill, it would be enforced if that level drops down below the lower threshold to
You
the
will
8%
take
range.
them to court.
Then alarm bells start going off, and Secretary of State steps in and says, you've got to bring your levels up. If that doesn't happen and it drops down to the 4% level, then they would be instructed to tap the reserves that they're holding for that purpose.
You hope they're holding, right? Because what happens if they don't hold that? Where's the teeth in this bill?
The teeth is if they don't do their job and things continue to deteriorate, then the Secretary of State can step in, request a receivership of the court to protect the cities and towns. Well, do you have anything you want to add to that? Christina? Yeah.
So I'd like to potentially address all of your questions in order, and the other representatives. First of all, the idea of an assessment is not essentially different to what Health Trust is already doing. Okay? They have internal targets for where the contingency reserves need to be. And as of right now today, in addition to collecting contributions to pay for healthcare, they're collecting an additional 5% mandatory. The towns and associations don't have a choice for it. They're calling it the capital risk charge. They're charging that to all of their members to help rebuild their contingency reserve back to where they want it to be.
They're doing that now.
No. Well, they started last year. Yes, they're doing
So they
that right
have put some money in. They seem to be addressing the problem now.
Well, the rate, I believe it was Senator Gray said, the rate that we're doing it, they actually strongly recommended, and you never hear actuaries talk like that. They're supposed to be impartial. Strongly recommended building over 2 years. They've gone with a 4-year plan. So whether they're following their actuaries, but they've attached a mandatory charge to replenish up to
So
a certain
aren't you
level.
guys monitoring what they're doing? Don't you get their financials on a monthly basis and know exactly how much their reserves are building or know what's going on?
Yes, we do.
Only if there's an examination. Normally in RSA 5B, there's an annual filing that is made by all the pools that contains their audit report, for example, and their actuarial analysis. But the reason that we get the monthly financials now is because of the examination, the investigation.
Okay. So have they started doing things and going in the right direction now? Then do you feel that there won't, that if we pass this legislation, and their claims, I see them have a pile of cards here, and I can imagine every one of them is going to tell me that they're going to go out of business because of it. You're going to tell me that that's not true, that they can absolutely continue to operate, and they will not need to do a special assessment on all the cities and towns.
Can you clarify? Are you asking my opinion on whether they'll need to do a special assessment?
Yes.
The likelihood is very low. And that's how actuaries talk. We use their own modeling to show that in a given year, if once they're back in the range, and this is their own actuarial modeling that was applicable to the law, the likelihood of an assessment is less than 5%. So obviously it can be zero, or else, why would it be in the law? But on an ongoing basis, that is the likelihood of needing an assessment. That's the likelihood of falling below that 4% in a given year. It's less than 5%. In addition, they have the option of self-funding, the amendment that the Secretary of State just introduced. Health trusts themselves can hold a fund restricted of up to 4% to pay that assessment on behalf of the political subdivisions. So even in that unlikely less than 5% chance that an assessment is levied, if Health Trust takes this option, and our indication from talking to them is that they will, if they take the option to pre-fund this special fund, they would pay it for the members anyway. So the likelihood of the members themselves having to pay a special assessment on a given year is probably more like in the 1% range.
Okay. Representative Gibbs.
Thank you, Mr. Chair. I'd like to ask the question that I asked an earlier speaker. He had said that the one of the goals being discussed is that the entities should have only a 5% risk of insolvency. So I asked, what is their current risk of insolvency? And he said he wasn't the right person to answer that. So can any of you answer that? Tell me, apparently there are 4 of these entities. One is imminently insolvent. There are 3 others that are not imminently insolvent, but apparently have a risk level of insolvency that is higher than 5%. So can you tell us, or can someone tell us, what that risk level is currently? Thanks.
So for specific numbers, my understanding is that Health Trust will come up. They're absolutely the people to ask for that. But I can tell you for sure, without the Senate bill, it's a certain level. With the Senate bill, the likelihood of insolvency is essentially 0. Right? It's the industry standard for how to prevent insolvency in risk pools. AGRIP, the Association of Governmental Risk Pools, they recommend this for all states. This is how you prevent insolvencies in risk pools. So whatever it is currently, and Health Trust will be able to speak to that, it will basically drop down to 0 with the Senate bill.
So, and where Health Trust is currently is, since we've been talking percentages, is somewhere under 10%. Part of the goal of SB 297 is, again, to set thresholds where you're not going to be in that position. They're at 8%, or they're at under 10%. And yes, they do have a plan to build that up and everything else, but it's a multi-year plan. What SB 297 would do is say, wherever you are, by next year, you need to be at least 12%. And, at that 12%, that is where it starts becoming, less likely that at some point during that following year that you will find yourself in that, oh, I'm under 4%, there needs to be an assessment, or
Right,
even worse.
But my question is, if they don't make the 12, are you going to put them in receivership?
I think it's that's a fact-specific question. It depends on the specific condition of the program and what they're facing and what they have to face it. and frankly what their plan is, because that's one of the initial steps that happen. We have the program. This is in SB 297. The program puts forth its proposed plan of correction to the Secretary of State. So they are the ones who have that in their court, so to speak, about creating a plan to resolve a deficiency. It's only when that either plan isn't followed through on or it gets much worse, where there's the Secretary of State having the authority to take further action. But whether or not they will be put in receivership is really depending on the situation that happens at that time and what they have
You
to
see,
work
that's the problem I have with this bill, is that it has these hard numbers in there.
Mhm.
The 12%, if you say, well, no, but if the 12, that the Secretary of State has wiggle room here. It doesn't seem that way. And I, I'll be frank, I think I made it obvious right from the beginning. When I first got involved with this issue, 15 years ago, whatever, that I've always had the position this should be done by the insurance department, because they're the ones who have a system to handle the solvency type issues. And they don't have these numbers written in statute. Okay? Only the Secretary of State has to have them, because you don't have rulemaking authority.
Well, I think as a comparison, if you're looking, for example, there's different statutes, but one would be regarding like Delta Dental, for example. They have in statute a certain contingency reserve fund that puts forth a specific range, a specific number for theirs. And I think here, it wouldn't be a situation, SB 297 doesn't provide for a situation where if you have less than 12%, you're going to move straight into receivership or at all in receivership. It merely sets forth different warning bells that go off and different ways to prevent someone from getting to that point in the first place, which right now RSA 5B doesn't include.
I was around when the Delta Dental legislation was passed, and yes, it's regulated by the insurance department. Okay.
I'd like to quickly just finish answering your question about the 12%, if that's okay, Mr. Chairman. I want to make clear what the 12% means. That's a threshold where at the end of a year, if the contingency reserve is below 12%, let's say it's at 11%, then in the following renewal, so it doesn't start for another year and it'll be collected over essentially 2 years, that shortfall, 1%, will be added to the regular annual contributions. It has absolutely nothing to do with either.
Like assessment on the cities and towns?
Well, it's what they're currently doing already. Right now, they're doing 5%. In my example, if it goes down to 7, then it would be 5%, right? But if it goes down to 11%, it will be 1%. So it's the system they already have. But instead of just letting them ignore their own actuarial recommendations for how quickly to do it, or use actuarial studies that are not relevant, the law states what it is, and essentially it does the same thing they do now, but with these specified ranges. I'm going to make it was always planned that I would make the closing remarks. It would literally take 1 minute.
Okay.
Literally 1 minute. So all of the concerns that have been brought up, either by the risk pools, such as Health Trust or NHMA, have now been addressed one of two ways. Either amendments that have been made, for example, the concerns about where do we find money for assessments, we created these funds, and then, how do cities manage it themselves? We amended to let the risk pools hold them. Or they've been addressed through, communications like the appendix that's attached to your document. Depending on what's said later, any concern that is essentially unfounded or invalid, we have already addressed. And I encourage you to reference that appendix depending on kind of what is happening later.
What is the appendix? I'm
So
sorry.
basically, after the first page, the rest is the appendix. We wanted to have.
I don't know appendix.
Oh, I'm sorry.
Appendix, we don't do that in our RSA. What does an appendix mean?
It's in this book. It's just
I see that, but what does that mean?
It just means it's additional information that we don't expect you to read.
But it's in the statute.
Oh, no. So this is the document that says summary of SB 297 at top. I believe
Okay.
you have the statute, but...
I have the bill.
Okay. So the document that says
So I
summary
have-
of 297,
Yeah.
after the first page, the rest of it is addressing concerns that either Health Trust or NHIT have brought up.
These are like asking questions and telling me what the answer is.
Well, concerns that they have brought up and that we provide the explanation
How you
for.
resolve them. I got you.
Exactly. Yeah.
All right.
So essentially, everything has been addressed. Things like fears that this would somehow transfer risk to the members, when in fact it reduces their risk. Things like there were some concerns expressed that the numbers being used, the thresholds of 4, 12, 16, are somehow not based on actuarial analysis. When one of the primary things we looked at was the risk pool's own actuarial analysis that they performed. That's relevant to the bill. Additionally, we looked at, for example, the worst ever losses they've ever had over the last 40 years for Health Trust in any length of time, whether it's 1, 2, 5 years, was about 17% of their annual contributions, the worst they've ever had. And then what the bill allows them to hold is, either 16 or 18, if approved by the secretary, plus the additional up to 4%. So essentially, they're allowed to hold up to 22. So which is well ahead of the worst loss that they've ever had. And so all of those types of concerns have been addressed in the appendix. Thank you.
Okay. Thank you very much. All right. Chair will call on Health Trust. Scott DeRoche and Jenny Herker.
More books to read.
Yeah, you leave them with the clerk. Yeah, that's fine. Okay. Good afternoon.
Good afternoon. Thank you for having us here today. My name's Scott DeRoche. I'm the Executive Director of Health Trust. With me is Gene Herrick, who's the General Counsel of Health Trust. I have a written prepared remark, but then look forward to questions. Sorry if I didn't distribute the packets correctly.
Key thing is to make sure you have the microphone close to you.
Is that good?
It's got to own that microphone.
Okay.
Yeah, all right.
I will. All right, thank you. Health Trust opposes this bill in its current form because it does not permit health risk pools to hold adequate capital necessary for long-term financial stability. To be clear, Health Trust recognizes that pooling of risk among political subdivisions of varied sizes and demographics is complex and nuanced, and has become more challenging as healthcare claims have become more volatile. Because of that, we are in favor of regulation through clearly articulated standards. The standards, however, must be actuarially sound and must allow risk pools to provide coverage in a manner that is both viable and valuable for the towns, cities, schools, counties, and other public sector employers and employees that we serve, and the taxpayers. The system that has been proposed in SB 297 is not based off of actuarial modeling nor reasonable standards. Since this bill became public 2 months ago, we have requested copies of the actuarial reports, models, and analysis that were used in developing the 12 to 16% contingency reserve at the center of this bill. We renewed our request last week and still have not received any documents showing that this framework is actuarially sound. Rather than modeling and testing the system through the application of sound actuarial methods, it appears that the system has been developed based on misapplying a short-term actuarial projection prepared for Health Trust by Health Trust external actuaries. The report was provided to the Secretary of State's office last spring to keep the regulator up to date on Health Trust's financial condition. SB 297, if passed, would require application of an arbitrary, low, and narrow level of reserves that quite literally relies on assessments from the public sector and through them taxpayers in order to remain solvent. SB 297 takes away the stability that RSA 5B is intended to provide that the public sector has come to rely on. We ask solely for a system to be introduced that is actuarially sound and provides a stable experience for the public sector entities that rely on risk pools. As background, risk pools were created in 1987 due to the inability of the private commercial market to meet the needs of New Hampshire's public sector. Today, risk pools typically provide more affordable and broader coverage than the private sector can provide. Additionally, as nonprofits that exist solely to serve the public sector, we are able to offer rating cycles, services, and support that relieves the burden on public sector entities throughout the state. As commercial insurers continue to decline to quote public sector groups, or quote excessively high rates, access to pooled risk management is now needed now as much as or more than it was in 1987. Health Trust provides a welfare and benefit program for New Hampshire's cities, towns, counties, and school districts. We currently serve 191 municipalities, 6 counties, 85 school districts, and 74 other governmental entities such as water districts, libraries, charter schools, and fire districts. These entities represent employers with very few employees to nearly 1,000 employees. We currently cover about 72,000 distinct individuals. Importantly, we remain the only entity that does not decline to quote any eligible political subdivision, regardless of size, demographics, or health status. Over the past 10 years, both nationally and locally, healthcare affordability for employers and employees has become a major issue. During and after COVID, claims volatility spiked due to individuals first postponing and then later seeking care. Additionally, new and expensive technologies, increased provider costs, and new utilization have driven significant increases on claims on a national level. These spikes further complicated the complex process of establishing renewal rates and highlighted the need for risk pools to maintain adequate capital. Reserves are critical, particularly in a volatile market, to ensure that claims are paid even in the face of larger than expected expenses. SB 297, as amended, would prevent Health Trust from holding the reserves its actuaries have deemed necessary in order to ensure claims are paid. Instead, SB 297 requires an arbitrary, low, and narrow level of reserves. In place of sufficient reserves, SB 297 requires that if a shortfall occur, member groups will pay additional assessments and replenishments in order to maintain solvency. This shifts the risk of the very member groups that we are meant to serve and exposes them to the volatility that RSA 5B was meant to protect against. This will result in a system that is more volatile for public sector employers and employees. If a significantly bad year occurs or a series of bad years, SB 297 will rely upon imposing steep rate increases and assessing the public sector and its taxpayers to ensure claims are paid. It is critically important that risk pools have sufficient reserves in order to cover expenses, particularly if an unexpected spike in claims occurs. Claims are by nature volatile. When calculating reserves, it's important that they are sufficient to survive events or a confluence of events that are unlikely but possible. For example, 1 in 20-year events or even 1 in 50-year events. When setting reserves, it is paramount to understand how a given reserve level will operate under various adverse conditions. A lower reserve level will likely be sufficient in an average year, where claims are slightly better or slightly worse than predicted. However, a higher reserve level is needed to survive the rarer but much more adverse years. The ability of cities, towns, school districts, and counties to raise funds from taxpayers to cover unexpected expenses is extraordinarily limited. Protection from risk can only occur if a risk pool has sufficient reserves to weather these challenging years. The reserve range introduced in SB 297 as amended, 12 to 16% of annual contributions, is too low and too narrow to provide such protection. While that range may work in a typical year, in a bad year or worse, 2 bad years in a row, it would prove insufficient to ensure solvency. As amended, SB 297 seems to acknowledge such insufficiency, requiring each member group to create, fund, and maintain their own reserves of at least 4% of contributions in order to pay required assessments and replenishments when the pool's reserves prove to be insufficient. Health Trust has experienced these events firsthand. In fiscal year 2021, we had a fully funded target contingency that equated to approximately 19.6% of expected contributions, having recently returned $57 million in return of surplus to the public sector. However, due to adverse claims experience in FY 2022 and FY 2023, the contingency reserve fell to 4.7% of expected contributions, a reduction of over 14.9% in 2 years. We are now in the midst of a multi-year rebuild plan. This is an example of reserves working as expected. No claims were unpaid. The risk pool remained solvent. Additionally, a reasonable rebuild is underway. As a result of this significant and dramatic use of reserves, the board has set a new target contingency reserve that would equate to 22.7% of contributions, so as to not fall so low again. SB 297 would not allow such prudent action. Rather, it would limit Health Trust's ability to accumulate capital for the protection of members and covered individuals. If we had begun the year towards the low or midpoint of the 12 to 16% range indicated by SB 297, the pool would have either gone insolvent or had to issue millions of dollars of unexpected assessments that would have unnecessarily burdened taxpayers and the towns, schools, cities, counties, and other entities we serve. Starting at the high end of the range, 16% would have left Health Trust with approximately 1% in reserves. That would be below the amount needed to have a reasonable confidence of short-term solvency and therefore requiring the pool to rescind offers of coverage for the upcoming renewal. The two other health risk pools in New Hampshire, School Care and New Hampshire Interlocal Trust, both currently operate in the reserve range required by SB 297. NHIT operates in accordance with a current risk pool practices agreement with the Secretary of State that has been in place since 2020, which requires them to have no more than a 15% reserve. After being fully reserved and giving back millions of dollars in return of surplus just 2 years ago, they are now unexpectedly closing, citing insufficient reserves to cover a recent unexpected spike in claims. School Care operates in a manner consistent with their expired risk pool practices agreement with the Secretary of State. It's my understanding that they ended FY 2024 with a reserve equating to approximately 9% of contributions, below the approximately 14% of contributions that they determined was required to have a high confidence to remain solvent through the current year. I reference these examples not in any way to disparage NHIT or School Care, but to further illustrate that the low reserve range, long championed by the Secretary's office and enshrined in SB 297, is not sufficient in the case of an unlikely but possible spike in claims. These spikes in claims are not hypothetical. They occur, particularly in the highly volatile current health industry, and have occurred to all three risk pools over the last several years. The Secretary of State has stated that the impact of reserves was due to rating practices rather than due to claim spikes. This is incorrect. We have conducted actuarial gain-loss reports that indicate the drivers of these losses were truly due to unexpectedly high claims. In one recent renewal, we rated for a 5.8% trend, but experienced a 14.5% claims trend, an increase of 2.5 times what our actuaries predicted. The fact remains that risk pools provide coverage that by nature contains risk. Actuaries cannot predict future claims based on expenses incurred almost 2 years in advance with certainty. When reality runs different than expectation, reserves are critical to protecting against insolvency. Any viable reserve model must be able to ride through unexpected claims in the current rating cycle and allow for recovery in future rating cycles. The political subdivisions of New Hampshire and their taxpayers need rate stability and protection from sudden losses. Mid-year or otherwise unexpected increases, whether through rate increases, assessments, or replenishments of the second highest budget item on municipal budgets, is not an acceptable solution. All three health risk pools ended FY 2024 with lower reserves than targeted as a result of adverse claims experience. We agree that reserves should be higher than they currently are. In the face of low reserves, the solution is not to enshrine into law a lower reserve range, nor is the solution to simply bill cities, towns, schools, counties, and other public sector entities millions of dollars in unexpected assessments and replenishments. The solution is to implement an actuarially sound methodology that ensures the public sector employers, employees, and taxpayers are protected. Any viable system for the financial stability of New Hampshire's risk pools must rely upon actuarial modeling at its backbone. There are many available models in use throughout the country and in New Hampshire that can be adapted to apply to New Hampshire risk pools. Chief among them is the risk-based capital, or RBC model, developed by the National Association of Insurance Commissioners and in use by the New Hampshire Insurance Department to ensure financial stability of insurers. The RBC model's entire focus is to ensure that appropriate levels of reserves are retained in order to ensure the solvency and viability of an insurer. It is a tried and true proven methodology supported by a full set of well-developed systems and standards. Rather than a fixed percentage of reserves, the system adapts to changes in the wider ecosystem, which is critical in a period of volatility. In conclusion, risk pooling is complex and nuanced, and it requires careful and thoughtful regulation. This is particularly true in a volatile healthcare market. The impacts and ramifications of SB 297 run far beyond an overly simplistic application of reserve requirements. Our member groups strongly desire rate stability and protection from risk. To date, the dialogue has been singularly focused on allowing only one model of health risk pool in New Hampshire and debating the absolute minimum reserve level needed to operate that model. SB 297 requires undercapitalization and relies upon assessments and one-year replenishments for solvency. The discussion should instead be focused on designing a system that allows more models of risk pools to exist, including those that provide additional protections and a more stable experience for political subdivisions and taxpayers. By forcing New Hampshire's cities, towns, counties, and school districts to bear the required undercapitalization, Senate Bill 297 threatens the very existence of the pooled risk management program that Health Trust offers and has served the vast majority of public sector employers well for nearly 40 years. If passed, this bill would limit coverage choices at a time when some political subdivisions, due to claims experience, are not able to even get a quote for medical coverage in the commercial market. We support reasonable standards and stand ready to work with any and all stakeholders to evaluate, craft, and implement such standards that will work for the public sector of New Hampshire.
Okay, thank you. Any questions from committee members?
I'll sleep.
I think we're all set.
Thank you.
Okay, for the other point of view, Brian Rill.
Good afternoon, Mr. Chair, honorable members of the committee. For the record, my name is Brian Rill, the president of the Professional Firefighters of New Hampshire, proudly representing roughly 2,000 active and retired firefighters across the Granite State. I'm also a 19-year member of the fire service. I'm here today to express my full support for Senate Bill 297 and the amendment that is before you today regarding pooled risk management systems. This afternoon, you've heard a great deal of technical information concerning how risk pools operate in New Hampshire, and I'll respectfully defer to the subject matter experts you've already heard from to speak on the financial and operational details of this issue. I'm here to offer a different but equally as important perspective, and that is that of the end user. The firefighters and other public employees who depend on these risk pool systems to provide stable, accessible health care for them and their families. Every day, our firefighters serve their communities selflessly, without hesitation or prejudice. And like thousands of public service servants across the state, they do so without asking for much in return. Simply fair wages, a secure retirement, and reliable health care. But today, as I understand it, that health care may be in jeopardy. As you've heard, the Secretary of State has raised serious concerns about Health Trust's operational practices that pose unnecessary risk to their financial condition and to the political subdivision members who rely on its services. While Health Trust has denied those concerns, I urge this committee to carefully consider the facts. As an example, a similar warning was issued by the Secretary regarding another risk pool provider, New Hampshire Interlocal Trust. That organization also rejected the Secretary's claims. Yet now, NHIT has stated it will dissolve its operation as of June 30th. I'll leave you to draw your own conclusions as to the reasons why. More pressing, and the main reason that I'm testifying today, is the systematic dismantling of member benefits that employees are experiencing under Health Trust, all under the guise of cost efficiency. Pooled risk management systems are meant to serve public entities by spreading risk and funding necessary healthcare expenses. Changes to benefits should be grounded in medical need and efficacy, not simply in cost cutting. Instead, we've seen sweeping, harmful changes, which include the elimination of critical prescription drug coverage, the imposition of restricted deductible caps, the reduction in retiree medical coverage, the termination of wellness programs, and coming soon, a cut to employee assistance programs, which are designed to offer mental health counseling, crisis intervention, wellness fitness plans, substance abuse services, and work-life balance support, all well-documented needs amongst firefighters and other first responders. None of these changes appear to be medically driven. If you review Health Trust board meeting minutes as I have, you'll find a singular justification repeated, and that is cost savings. Nobody, certainly not our members, want to see the cost of healthcare rise.
But when we pay our premiums, we expect to receive the benefits that we were promised, benefits that are often guaranteed through collective bargaining agreements. Recently, a member shared with me that a spouse of one of our firefighters was denied access to her prescription drug treatment for her cancer, a medication that had previously been covered by Health Trust. For anyone to spend a career running toward danger to protect his or her community in this state, have their loved one denied proper health care in return is completely unacceptable, and I believe that you would all agree. So I asked this committee, do these actions reflect a financially secure organization? One that claims to be financially viable, have millions of dollars in financial gains, exceptional cash flow, and reserves well above the assessment threshold that are outlined in Senate Bill 297. If they truly do, then why are benefits being stripped from the very people who rely on them most? This question remains unanswered, and I believe that political subdivisions and their employees are entitled to one. The Secretary of State's actuaries made it clear. Health Trust problems stem from years of questionable operational decisions. Senate Bill 297 offers a solution by setting guidelines for adequate contingency reserves and sets a standard for risk pools to maintain a proper standard of care. Yet rather than present a viable alternative, Health Trust has chosen to instead simply reject the bill outright, further stating that if Senate Bill 297 passes, then they will be forced to dissolve their operations. I'd ask the committee if this sounds like a proper response to a stable, viable organization. While I do not claim to be an expert in actuarial science, I do know this. Transparency and accountability are essential to any system of governance. Senate Bill 297 seems to provide both. It's time for risk pools in New Hampshire to reevaluate their financial and operational strategies to address the root causes of their organizational instability. The reckless practice of sacrificing member benefits to address perceived or actual operational deficiencies must end. On behalf of the professional firefighters of New Hampshire, I urge this committee to support the Secretary of State and pass Senate Bill 297. Thank you for your consideration.
Well, I gotta ask the question. If you think that they're doing all kind of those benefits is a bad thing, where are they going to get the money for to get their reserves up?
So, as I mentioned in my testimony, thank you for the question, Mr. Chair. As I mentioned, we negotiate benefits with our cities and towns. We also pay premiums to cover those benefits. At that time, when we negotiate those benefits, we expect to get those benefits based on those premiums and actuarial analysis. If risk pools are intentionally undercharging on the rates to compete for market share, this does not accomplish the goal of providing the adequate benefits.
So what you're saying is they should just raise the rates to the cities and towns.
I'm
The cities
saying-
and towns pay to taxpayers should be that's their responsibility is to make these entities work.
So from what I understand from both sides of the discussion is the rates will be increasing regardless. My position would be if the rates are going to increase, we want the benefits to reflect that.
Well, that's not what your testimony said was that you want, basically you're saying they've already made these cuts. And the cuts were used to get their books, at least get some monies on the reserves. So what you're saying is basically you think that this problem is the cities and towns aren't paying enough.
It sounds to me like the cities and towns are not paying enough right now. And regardless of whether or not this passes, they're going to be paying more on the rates. And my statement is...
And that's okay.
Well, as I mentioned, no one wants rates to increase, right? But if we're promised a benefit and we have to pay for that benefit, then if we're paying, we would like to receive the benefit. So if the rates increase some amount to cover the benefit, then that's unfortunately what has to happen.
So, right, but there's no protection of that in this bill. But basically, the only way, if they're using your benefits as the way to satisfy what this bill requires them to have the reserves, I would have to tell you, expect to see more benefits cut.
So what draws my attention to this bill is in the bill's analysis, it speaks to implementing a requirement for a proper standard of care, which is what entices me to support it. because as it stands right now, it does not feel as though they're exercising that standard of care. It feels as though there's arbitrary cuts to medical benefits based solely in cost and not in medical efficacy. And at least in the bill's analysis, the standard of care would help to steer that a different direction.
Okay. Thank you very much. Sure. All right. Chair will call on Margaret Burns, New Hampshire Municipal Association. Oh, you're, yep. You're right.
I'm going to get his testimony.
So, excuse me, Brian, could you give your copy of your testimony to the clerk? That'd be great. Thank you.
Thank you. Good afternoon. I'm Margaret Burns. I'm the Executive Director of the New Hampshire Municipal Association. My colleague is handing out copies of written testimony, and we are here today in opposition to Senate Bill 297. While NHMA takes no position on whether cities and towns should obtain their coverage from risk pools, as a statewide organization representing all 234 cities and towns, we stand for local control, which includes the right of municipalities to form, join, and govern pools if they choose to do so. With one health pool now announcing it will no longer offer coverage and another determining it could not offer coverage under the model proposed in Senate Bill 297, the bill threatens this choice, negatively affecting public sector employees and taxpayers. Our opposition is primarily focused on the manner in which the bill affects health pools differently than it affects property casualty pools. I also wish to note that although we have heard mention of an amendment that quote unquote addresses all our concerns, I have not seen such an amendment, and our concerns remain with the bill as drafted. There are three primary reasons for our opposition. The first is that the bill creates unlimited financial risk and liability for local governments that are members of risk pools, coupled with essentially a surprise billing model for assessments or replenishment when the pool's reserves fall below certain levels or when they are considered insolvent, impaired, or unable to discharge their liabilities. Municipalities do not simply have a rainy day fund they can pull from to plan for these unplanned bills, and of course, these assessments mean additional costs for taxpayers. Second, and seemingly to address that concern, the bill as amended by the Senate mandates that members of health pools establish local reserve funds referred to as health stabilization funds. In addition to raising costs, it's unclear what happens if a municipality fails to establish the fund, fails to appropriate the 1%, or what happens if the 4% that's in your reserve fund is insufficient to pay the surprise bill that you receive. And frankly, the fact that the bill includes a mandate for these reserve funds for health pools only tends to show, or perhaps even admits in its drafting, that the contingency reserve levels set for health pools are insufficient and that there is likely to be a reliance on local reserve funds to fund the contingency levels of the pools to meet the standards of the statute. And yet here today, I've heard both that it's highly unlikely that this would happen, and I've also heard, frankly, that it's not so different than what Health Trust, for example, is already doing by building in the capital risk charge to bring their reserves back up to the level that their actuaries have determined that they should. Our third reason for opposition is that I would submit to you that this model is detrimental to the solvency of risk pools, and in fact, we have already seen that happen. Due to low reserves and the need to return surplus to remain within certain reserve levels set by the Secretary of State's office, coupled with the volatility of health claims that all three pools have experienced, interlocal trust has essentially been regulated into insolvency. And the bill threatens the same demise for the other health pools. In fact, if this bill were the law today, interlocal trust's position would require that assessments be levied or replenishments be levied on the local governments that are members of the risk pools. We find this to be an untenable position for local government members of health pools. We certainly agree that standards are needed to evaluate contingency reserves necessary to maintain financial stability. We agree we need a process that allows the regulator to take timely corrective action to abate financial deficiencies. And we certainly agree that clarifying the obligation of board members to act in the best interest of political subdivisions makes perfect sense. However, for the most part, this bill does not do that. And we understand that no actuarial analysis was performed to determine the outcome for health pools under this model. For this reason, the New Hampshire Municipal Association Board of Directors, in addition to opposing the bill as written, voted to also support an amendment that would move the risk pools to the Insurance Department for oversight and regulation. As the Commissioner of the New Hampshire Department of Insurance testified at the Senate Finance Committee hearing on this bill, his department does have in place standards and expert staff to take on oversight should that happen. If there is another solution short of moving to the New Hampshire Department of Insurance that would create an equally stable system that supports solvency and properly regulated pools, we would certainly support that as well. However, I would suggest that any new model that would be codified into law must have an actuarial assessment done before that occurs. Thank you very much for your time. Happy to take any questions.
Representative Burrows.
Thanks for taking my question. This is just a curiosity. What is the relationship to Health Trust and the Municipal Association?
Great question. We're in the same building. There used to be a formal relationship between us, but as you know, the local government center no longer exists, so we are two entirely separate organizations. They do sponsor some of our events, and in conjunction with that, we also market their them in response for a sponsorship for our events.
Just quick follow up, because I was surprised to see it on your website. You have a big thing, or, looks like promoting them.
We do, and we also have as a sponsor Interlocal Trust. So they're also part of what we promote in our advertising in our magazine. And because you asked the question, as far as relationship goes, I also want to mention that we are a member of Health Trust for our insurance.
Representative Ammon.
Thank you. I just want to follow up on the previous question. So if I go to your website and I click on partners, it says that Health Trust is a partner. New Hampshire Municipal Association is pleased to partner with these organizations. Health Trust is listed. Do you give Health Trust money for your premiums or your benefits?
We are a member, so we pay. Yes, we pay rates to be a member.
Does Health Trust contribute to the Municipal Association?
That's correct. They sponsor a number of different organizations, as I understand it. And
how much money do you receive from Health Trust?
$25,000
a year.
That's correct.
And where does that money come from?
Where does it come from? On the Health Trust side?
Yeah.
I can't speak to that.
Nothing's easy in this committee. Representative Gibbs.
Thank you, Mr. Chair, and thank you for coming to testify today. Do I understand correctly from some of the written items that have been passed around that a number of municipalities have in recent years found it impossible to buy health insurance from commercial providers?
We were not aware of that until this bill came out, and we started to talk to our members more about what they've experienced. And we learned that members have actually been rejected by the private market. Private market has refused to quote some of our members entirely, and that even the other two smaller health pools, Interlocal Trust and School Care, have declined to quote some of our members, meaning that at the end of the day, Health Trust remains their only option. We do understand that has been the case for some of our municipalities.
Further question, may inquire.
Thank you. Has there been any explanation as to why they've refused to provide these quotes?
I don't want to guess, but what we understand is it often has to do with either the size of the group or their prior claims data. Potentially having a lot of unhealthy people in the pool can be a deterrent because it creates more potential liability. But no, I don't have a list of the reasons that they received when they were declined to be quoted for those other entities.
Thank you very much.
Thank you.
Chair will call on Ty Gagne from Primex.
Thank you. Not here very often, so sorry about that. Okay.
Close.
My colleague is passing around my testimony. My name is Ty Gagne, and I'm the Chief Executive Officer of Primex, a position I've held since 2008. I'm here this afternoon to voice support for Senate Bill 297 as amended by the Senate insofar as it applies to property casualty coverage. Primex is a pooled risk management program located in Concord, New Hampshire. We operate under RSA 5B in the form of a trust to provide property casualty coverages, including property, liability, workers' compensation, and unemployment compensation to 574 government entities throughout the state. We've been in existence since 1979 and cover over $13 billion in member property value and $2.6 billion in member employee payroll. To control our shared risk, we provide members a wide array of risk management services and training programs. Primex's core values are trust, excellence, and service. Essential to our values and mission is the risk pool's financial strength. Primex has worked with the Secretary of State's office on many occasions regarding the determination of reserves and surplus. We have advocated for the ability to hold sufficient capital to ensure solvency, while at the same time recognizing the importance of returning surplus funds to our members. Through this collaborative approach, Primex has been able to strike a balance and maintain strong financial health. Senate Bill 297 is a risk pool solvency bill. We believe risk pool solvency is critically important for Primex and its members. The bill's contingency reserve levels will allow us to retain more reserve funds than we currently hold, further strengthening the risk pool. While we're still in audit for 2024, we currently estimate that our claims and contingency reserves are already fully funded. Primex will be in compliance with Senate Bill 297's reserve levels well in advance of the effective date. Senate Bill 297 also grants replenishment and assessment powers to prevent risk pool insolvency. We don't view such funding provisions as problematic for Primex. The Primex Trust Agreement already allows for member assessments, but we've never had to use them. Under Senate Bill 297, we expect we will continue to avoid the need for member assessments. Attached, you'll find an overview of Primex information, including details on our financial position. Thank you for your consideration of my testimony this afternoon.
Great. Have you ever done a rebate?
We have done a return of surplus. We did a controlled return of over $60 million over 3 years under a risk pool practices agreement that we reached with the Secretary of State and Bureau of Securities in 2012. At the conclusion of that risk pool practice agreement, we did another return of surplus because we had unrestricted net assets at the end of a fund year.
And when was that?
Great question. 2019. I can go back and get the exact. But I
So
believe
that
it
would
was
have been the
2000.
last time you guys
Yes.
rebated money back.
Yes.
Okay. And how much was that? I'm sorry.
It was approximately $12 to $13 million.
Okay. Representative Spear.
In trying to remember everything that you said, you folks don't really deal with health insurance, health related things. You're mostly casualty and property casualty kind of thing, right?
That's correct. I can't speak to the concerns of the health pools today, only property casualty.
Workers' comp is theoretically
Right.
healthcare, but,
Okay, so it's very different. Thank you.
but you got to get her on the job. Okay. No? Yes. We're all set.
Thank you.
Yep.
Thank you for your time.
Okay, I have a pile of cards of people who are in opposition, but I have 2 cards of people who are neutral. So, and they both seem to be worthy to testify now. Lisa Duquette from School Care. We haven't heard too much from them. Good afternoon.
Good afternoon. I have some prepared comments. So, Chairman Hunt and honorable members of the committee, thank you for the opportunity to support the Secretary of State's proposed amendment to SB 297. First, I want to share that my name is Lisa Duquette. I'm the Executive Director of School Care. I've served in this capacity for 19 years, and I've worked in a public entity risk pool for 29 years. School Care currently serves approximately 90 public entities and about 20,000 lives in the state of New Hampshire. It is primarily school districts, but we do have a number of municipalities in our program, housing authorities, and water districts. School Care is expanding its health coverage to New Hampshire political subdivisions, the schools, the municipalities, counties, and others. Let me elaborate for just a minute on what I mean by expanding. On this past Monday, April 21st, the School Care Board of Directors acted swiftly and decisively to set up, on behalf of the public entities facing disruption in employee health benefits as a result of the New Hampshire Interlocal Trust ceasing operations on June 30th of 2025. Understanding the uncertainty of this announcement School Care committed to ensuring continuity of coverage and administrative support for any political subdivision seeking an alternative path forward. Our longstanding experience in pooled risk management, having operated now for 30 years, being created in 1995, and now our new partnership with Harvard Pilgrim Healthcare positions School Care to provide stable and supportive options both on July 1st and into the future. However, it's critically important for me to emphasize that School Care firmly believes that all options should remain on the table for New Hampshire public political subdivisions. Whether a public entity chooses to access coverage directly through a preferred insurance carrier, using a broker or a consultant, or through a public entity risk pool such as School Care, the system should support that flexibility. In School Care's case, that means that political subdivisions can obtain coverage directly from Cigna and Harvard Pilgrim, which are now our partner carriers, as well as through the School Care risk pool. New Hampshire public entities deserve a choice in how they obtain their employee health benefits, one that fits their operational needs, governance structure, and fiscal goals. With that, I would like to continue to express School Care's strong support for the amendments restructuring of reserve requirements as presented by the Secretary of State's office today, specifically the removal of the mandate that each political subdivision maintains its own 4% healthcare reserve fund and the introduction of a restricted fund held by the Pooled Risk Management Program. The proposed amendment offers a far more practical and fiscally sound alternative. It allows a pooled risk management program to set aside up to 4% of its prior year's contributions in this restricted fund balance, sourced from earnings and surplus, specifically for the purpose of funding assessments. This approach ensures that sufficient reserves are available in the event of a deficit without requiring every individual member to establish and maintain separate accounts. Importantly, this restricted reserve is capped at 4%, and it can't be used for any other purpose other than assessments. Money needs to be drawn from this fund before assessments are issued to members. And it is separate from the pool's contingency reserve, meaning maintaining transparency in reserve reporting. We believe this amendment preserves fiscal safeguards, improves administrative efficiency, and reinforces the core principle of pooled risk, that members share both resources and risks collectively. Finally, I do want to express my appreciation to the Secretary of State and his staff for their willingness to engage with stakeholders through the process. Their responsive feedback and openness to collaboration resulted in what we believe is a well-crafted amendment that reflects the needs of political subdivisions while strengthening oversight and sustainability of pooled risk management programs in New Hampshire. Thank you for considering this common sense improvement to the statute. I urge your support of the amendment, and I'd be happy to answer any questions.
Okay, we're just going to make sure we're all on the same page. So the amendment you're talking about is what's already in the bill, that the Senate amended this?
No,
didn't
this, I'm referring to the Secretary of State's proposed amendment that he discussed during testimony
it?
today.
Oh, yeah. Yeah. Aren't you lucky to get to see it? We have not seen that.
Okay.
So I do remember some. Okay. All right. Okay. So you are in support of this amendment. Okay. And my next question is, are you like a broker, or are you in terms of the what school care does? I mean, you keep talking about Harvard as a partner. So is Harvard actually the health plan itself, or I guess I'm confused.
School Care is a public entity risk pool currently
Is a
operating
ri-
today
Okay.
under RSA 5B and has been for the last 30 years.
Okay.
Today, our relationship and the programs that we provide for political subdivisions is through our, I call it a partnership.
Partnership.
With Cigna. We have now established a second partnership, an administrative services only arrangement
Okay.
with Harvard Pilgrim to be able to continue offering the plans that the New Hampshire Interlocal Trust members currently have today.
Okay. So make sure I understand this, because I know Cigna is a big player in the ERISA market. So is that they're when you set up some school district or some school that you're setting up, Cigna is the one that does the administrative process of billing and getting
No,
the-
that's
the
so we
paying out?
operate. We're a health pool. We're just like health trusts.
Okay.
So we have an administrative services agreement
Okay.
with Cigna. We pay a fixed fee per month for
Right.
access to their network and for them
Their
to
network.
adjudicate claims.
And they
on our
adjudicate,
behalf.
right? That's what I'm saying. They're your facility operating for, let's say, pay the bills to the providers. They write the checks.
Well, from our account, but yes,
Yeah. Okay.
it's a self-funded program.
Like ERISA.
It is not an ERISA plan.
Well, we know it's not an ERISA because it can't be ERISA. It's a 5B. It's a risk pool. But has been, I don't know if you heard earlier in the testimony, but how the Secretary of State Scanlon, when they first talked about what the 5Bs are, the risk pools, they are similar to ERISA, but they're communities coming together
Correct.
to create an ERISA.
100%.
But I just understand. I want to make sure I understand that these are your operators. They do the what we call the backroom stuff.
They do.
Okay. Any other questions from the committee members? Oh, Representative Gibbs.
Thank you, Mr. Chair, and thank you for coming in to testify and answer our questions today. You mentioned, if I understood you correctly, that any political subdivision would be able to get health insurance through Harvard Pilgrim. Did I understand that correctly?
That is correct. So we do believe that Harvard Pilgrim is currently quoting groups directly as well as Cigna.
But according to the New Hampshire Municipal Association, many municipalities have recently tried to get quotes both from commercial insurance plans and from other risk pools, and none of them would provide quotes except for health trusts. So is there any way to reconcile that?
I can only speak for school care. School care does, from time to time, indicate that we cannot provide a competitive, what we would call a competitive price quote. And in that case, I can think of a community in the North Country approximately a year ago that had very high claims experience. And we would have needed to deliver rates that were 150% over their current rates. So a 50% increase. And rather than, I will say, feeling like we're insulting them with these rates, I spent a lot of time with this municipal manager explaining their claims experience and strategies that they might be able to use with their current provider. So we don't want to close the doors, but typically it really means every time school care says we can't give you competitive pricing, we give an explanation about what's going on with claims experience and how we can't beat your current renewal rates.
Thank you very much. Okay, Megan Tuttle, NEA New Hampshire, and also neutral.
Good afternoon, Chairman, members of the committee. For the record, my name is Megan Tuttle. I'm president of NEA New Hampshire, and we represent about 16,000 plus members, educators across the state. We're neutral on this in the sense that our concern coming out of this bill, or what comes out of this bill, is that my members have health insurance that's affordable and that they can count on. So I'm going to keep this very short. We're willing to work with the committee on how to get that and make sure that that's the end goal. That's all I have. So, I know it's getting late and there's a lot of
Who
people
can
behind me.
argue with that?
But I'll take any questions if you have them.
Okay. Do you have any fears that this bill might mean that your premium, that the premiums for the schools would have to go up?
I think it's a possibility. I can't say for sure yes or no on that. Just for the record, I do have members that are part of School Care Health Trust, and they were part of Interlocal as well. So that's why we're waiting to see what happens with this.
And are you happy with the benefits?
I don't personally have them. I'm through
Right.
a
I mean,
completely different plan.
are your members happy with the benefits?
I've heard different things for that. Thank you for the question. I've heard that some members are very happy with their health insurance and the benefits they're getting. I've also heard lately that there are some concerns about medications that were stopped. According to the members, they went to the pharmacy to fill those medications and were told they had to pay out of pocket. So I've been hearing different stories, I guess you could say, different experiences based on who they're with.
Great. Thank you very much.
Thank you.
Okay. So I have a pile of cards here. I counted up. It would be an hour to go through all these things. So all I can ask is try to say something new or something we haven't heard yet. But if you want to just come up and say, I'm opposed to the bill, that's okay too. And so we'll start with Morgan Dubois or Ray Gorman. It's like two different. Speak with. Okay, two people. There we go. You just start with that and they'll pass it around. Okay. You have to pull it close to you.
Thank you. Good afternoon. I will keep this brief. My name is Morgan DuBois. I am the Human Resources Director for Coos County. We have been a longstanding member with both New Hampshire Interlocal Trust and Health Trust for many years now for both our employees and our retirees. We've continued to accommodate rising health insurance costs while, of course, doing our best to maintain a pretty financial picture year after year. As we do each year, we signed the annual not to exceed contract provided by New Hampshire Interlocal Trust at a rate of 8.5%. Conversations with New Hampshire Interlocal Trust continued to be positive with no inclination of change or fear of change given the circumstances. And we passed our annual budget on March 24th, given the facts and figures from this document. Unfortunately, 4 days later, we received the call from New Hampshire Interlocal Trust that they are going to be breaching this contract. And instead, the rate for July 1 renewal of this year is not going to be the 8.5%. It will be 39.6%. Immediately, we began looking for alternative coverage options with an almost impossible timeline. Even if coverage with New Hampshire Interlocal Trust was still an option, the quadruple rate increase would have an annual budget impact of almost $1.7 million. And that doesn't take into consideration the $100 to $350 a month difference for my employees. Yesterday, we were informed of the partnership between Harvard Pilgrim and School Care to honor the final rate presented by New Hampshire Interlocal Trust. And as I've stated, for Coos County, this is simply not an option at 40%. COAS relies heavily on our employees in an area that is already pressed for employment population and employment opportunity. And it does not sit well with me to inform our employees that the insurance that they have come to rely on is discontinuing our coverage at the 11th hour. It causes fear in employees, it causes uncertainty, and those employees rely on us at the end of the day to provide them with health insurance coverage they can be certain of. The drastic financial implications of these rate changes, coverage cancellations, and regulations are simply not an option for Coas County at this time. And I'll leave it open to questions.
You're not going to see too many questions at this time.
Okay.
Thank you, folks, for having us here to speak. We're just, there's a sense of urgency you can sell by what Morgan was telling us. Or, July 1st is here. We were going to start tomorrow putting out the next insurance plan to our employees. I also represent the town of Colebrook as a selectman. So there's total chaos in all these small communities that it's very difficult, and we're economically depressed, et cetera. You folks have heard a lot today. I don't know how you figured it out, but good luck. And I'm being blunt. I mean, I'm sorry, but we do the best you can, and please remember those small towns and get us into a bigger risk pool so our rates go down, please. Thank you.
Oh, we do have a question.
Just a quick one. I mean,
Sure.
as a selectman, I don't know what you're doing, dealing with a 39% rate increase, and that's.
Well,
my question is, have you found other coverage? Have you found responses?
So this has happened. You don't get new rates in a week. You just don't. So we got a meeting Monday, and we believe we might have 3 to 4 proposals, but we're just scared to death of the numbers. Okay, and it's just brutal. We're scared.
Let us know what happens.
Yeah, follow up on that.
Please let us know what happens.
I certainly will.
Thank you.
Can it be worse than 39%?
I hope not. I don't know how it's for the county, for the towns like Colebrook and stuff like that. Gorham's is another one of my towns that I represent as a county commissioner. There's several towns in Coos County and we're all in a tough spot. And the budgets we had to propose to get through our communities this spring, we had a 60-cent increase on the town level, and we were lucky to get that through. And the school had a 0% increase because we knew nothing was going to go through that was higher. We're in a tough spot. We got to get the balsams going again. We need a lot of stuff happening right for us. I mean, it is what it is, folks. Yeah, cross your fingers for me, please. Okay, thank you. What's that?
I shouldn't have just blurted that out. Is the Balsams going to open again?
I have personally, ma'am, I worked there for 32 years. I talk to Les Otten every month. I've been talking to him now every week, possibly meeting with him at the end of this week about the Golf Links Road. There's a lot of things they're trying to finalize right now, and it looks like they might be, that long hill they've been going up, they might have reached it. They're getting very close. Financing is a big part of it, and that's where they're at now. So it's looking good.
Right. It's not going to happen this summer. Okay. Thank you very much. All right. Paul Deshane, Town of Newington. Good afternoon.
Good afternoon. Thank you very much for the opportunity to address you this afternoon, and I will be brief also. You've been through a lot today. My name is Paul Deshane. I'm the project manager for the town of Newington, and I'm here at the behest of the Board of Selectmen of Newington, who passed the resolution that I passed out before you, stating their opposition to Senate Bill 297 as currently drafted. Of course, there's been alluded to an amendment. We haven't seen the amendment, so I can't speak to the amendment. But as a general premise, the bill seems fatally flawed on a number of levels that have already been spoken to by the Municipal Association and the Health Trust and others. I would just leave you with my personal observation that there's an irony here that's not lost on me and anyone who's been involved in the pooled risk management programs over the past decade. At that time, public risk pools that existed were targeted by the Secretary of State's office of holding too much money in reserves. Now, 10 years later, we're in a circumstance where they're proposing a bill that says we need to hold more. So that irony just is infuriating to many of us. I don't want to state the obvious, but it seems to be true. I don't understand the logic. And perhaps that is one of the main reasons why moving into the Insurance Bureau is a more appropriate regulator, given this whipsaw type effect. So I'll leave it at that. Thank you.
Okay, I agree. Thank you. Michael Coutu?
Good afternoon, Mr. Chair and members of the committee. My name is Mike Coutu. I'm on the Board of Selectmen for the Town of Rye. I might note that you made a very astute observation about the return of earned surplus. In fiscal year 21, Health Trust had a return surplus of $38 million. Had that been deferred for, let's say, 3 years or so, all right, that money would have been available to soften and cushion the losses that were COVID related in fiscal 22 and 23. So a bit of my background might be interesting to the committee. I first got involved in risk pools in 2010 when Earl Wingate, who was a staff attorney for the BSR, was investigating the operations of Health Trust and local government center generally. It was an investigation that was based on a complaint that was filed by the professional firefighters of New Hampshire, who cited a number of issues, one as being the excess amount of capital in risk pools, and number two, more importantly, that there were monies which were cash that was taken out of Health Trust in the form of dividends upstream to the parent company, local government center, and then downstreamed into property liability trusts for use by Workers' Comp Trust, which was a separate standalone until it merged into PLT. So what was happening at the time is Workers' Comp Trust was underquoting pricing in the market in its competitive nature against Primex. So that then led to the administrative hearing, which was commenced in 2011, and I was the expert witness for the state on both financial and insurance matters in that litigation. I might also note that I was the fellow who negotiated the settlements with Primex and School Care in 2012. I handled the financial part of it, and Andy Valinsko handled the legal parts. I also testified before Senator Jeannie Forrester in 2015. When she looked at the risk pools, I testified on changes that I thought were needed and necessary in the context of the then existing 5B. So let me just cut to the chase. I am not, and my town is not supporting this bill. Small towns cannot be and do not want to be in the business of being participating players in the risk market. What we want is the ability to pay a price, call it a fixed cost or guaranteed cost, for the coverages that we need, and not have potentially a contingent liability of one kind or another, be it assessment, contingency replenishment, or other costs that may be pushed back to the municipalities. I think, Mr. Chair, as you've noted, at the end of the day, that, to the extent that we have these assessments, derivatively, they get passed on to the taxpayers. So you got the issue of not only the municipalities, which are always struggling from a budgetary and finance point of view, but having these, I'll call it, known metrics with unknown impact in terms of these assessments or replenishments constitutes an exposure that most small towns do not wish to have. Number two, the question has been debated here to some extent about the question of where is the best home for risk pools. Now, I've been in the insurance business a long time. My career was running insurance companies that were in financial distress. I run insurance companies here in the US and also in Europe. So I think I know a little bit about insolvency. And what I would tell you is that what we have here conceptually, all right, forget what the statute says, is an insurance operation, okay? It works like an insurance operation, all right? It has reserves on the balance sheet called loss reserves, all right? It has, capital, which here we call it contingency reserve. I have no idea why. It's capital or net position and accounting speak, all right? And to have this under the auspices of the Secretary of State going back to 1987, in my judgment, never made sense. Now, I might also add as a footnote that I worked for Bill Gardner and for Barry Glennon. I was their financial and insurance consultant for 3 years. So perhaps I know something about 5Bs. So the best place that this belongs is under the Department of Insurance, have it regulated as an insurance operation, and in addition to that, the rules and regulations of an insurance operation are more rigid than those currently in 5B. For example, we hear the term contingency reserve, all right? Again, it's really capital. Now, there's an ongoing battle that's been going on between Secretary of State and risk pools on what is the level of satisfactory contingency reserve read capital, all right? Well, insurance companies have dealt with this issue for many years. And so something called the National Association of Insurance Commissioners, or NAIC, all right, long ago developed what's called a risk-based capital model. It's a fairly complex model, but it's very effective. It looks at the assets and liabilities of the balance sheets, it assigns a risk factor, and based on a formula calculation, will determine what is the appropriate level of capital that an insurance company should have. All right? That's what should be applied here. In fact, HealthTrust early on, when it was the argument of having too much capital, was using a risk-based capital model. Okay? Now, if you ask me if in my judgment, going back to 2012, thereabouts, during the time that the litigation was brought by the BSR against local government center, did HealthTrust at that time have excess capital in its balance sheet? It did. All right. However, since then, and as a result of the Supreme Court decision that was made in 2014, in the SOS implementation with respect to capital levels, in my judgment, the current SOS required or decreed capital levels is not sufficient. All right? It's not sufficient. So I don't think that SB 297 is going to fix your problem. All right? I also feel that putting it under the auspices of the Department of Insurance is beneficial, not only because of its more stricter capital requirements, but also they have a much sharper eye on what we call the actual determination of reserves. Reserves is used very loosely in risk pools, but in traditional insurance speak, reserves include things like, all right, loss reserves, and something called IBNR, all right, which took me about 10 years to figure out what that was. But IBNR is the concept where actual determination is made in connection with losses that have occurred but have not yet been reported or paid, okay? So it's an actuarial level, but it is one of the reserve levels that they have to set aside. And in my judgment, all right, I believe the whole reserve oversight under the auspices of the Department of Insurance would be more acute. So, we have this debate about reserves and levels, and there's too much reserves, what have you. And let me tell you about the insurance industry, all right? What happens is independent actuaries come up with a range of values for what is determined to be the adequacy of reserves. And so they have a low range, or a minimum, and they have a high range. And they have something in the middle that we used to call for years the midpoint. Can't do that anymore. Actuaries don't like it, all right? What they call it now is the actual central estimate. Now, I've also been on the regulatory side. For example, I was brought in by the insurance commissioner for the state of Illinois in connection with an insurance company called Kemper Insurance Company. And from a regulatory point, wearing that hat, I applauded insurance companies that climbed in the range. So what that means is if they were at the low end of the range, they would financially do what's necessary to grow in the range. In other words, have more fat on the bones. All right? That's climbing in the range. We don't have that concept under 5B and under the regulation of Secretary of State. So my bottom line is if you really want to fix this risk pool business and develop a more solvent ability in terms of what is currently the regulations and statutes under the insurance commissioner, move it. All right. Amend 5B simply by saying, all right, that 5B would be regulated under and under the auspices of the insurance department of the state of New Hampshire. Thank you.
And for the record, we've never met, right?
No.
Representative Gibbs has a question if you're willing to take one.
Sure.
Thank you, Mr. Chair, and thank you for coming to testify today. Given your town's concerns about special assessments under the risk management pool arrangement, has the town tried to purchase group insurance in the private market? And if you did, what was the outcome?
Well, it's an interesting question. I might note that I'm giving a presentation in Rockingham County towns and cities tomorrow night. The 32-page PowerPoint presentation, okay?
Send us a copy.
And I'm going to leave this with
Send-
you because it does a deep analysis of SB 297. I also put together some mathematical examples of how these different triggers, as I call them, work, and use an illustration of what the assessments would be. One of the things I'm advocating in my presentation tomorrow evening is, in addition to the recommendation of putting this under the auspices of the insurance department, is to explore other options, meaning commercial or private markets. So the 5 biggest players on the healthcare side here in New Hampshire is Anthem, then we have Aetna, we have Tufts, we have Harvard Pilgrim, and we have United Healthcare. Now, there were comments made about one of the other prior individuals were testifying that it's difficult to get coverage in the commercial market. So let me explain that a little bit. All right. So when
Well, I mean, I hate to do this to you.
Yeah.
Because we got a lot of cards and we have to be out of here by 5 o'clock.
All right.
So do you mind? Do you
You've been
mind?
gracious enough to give me this time.
What I was asking was, is your town able to get group insurance in the private market?
We haven't gone down that road yet, but we have it on the table to pursue.
Thank you.
And please just send it to me electronically. My webpage is, my address is on the webpage.
All right, I will
but
do.
I can't handle too much paper.
Any
So-
more questions before I leave?
No, you've
Thank you.
done great. Thank you. Yeah, I will then forward it. Okay. Morgan Dubois. Still here? Dubois? Deblois? I thought I was good at my French. Okay, Coos County, but all right. But what's that? Oh, she had 2 cards in? All right, Scott Gross.
Good afternoon, Chairman Hunt and the rest of the committee members. My name is Scott Gross. I'm the business administrator for SAU 19, represents New Boston and Goffstown. I do oppose this bill, so does my school districts. I think one thing that was eminently clear from today, and certainly from the Senate hearing, was this bill is not ready for prime time. It just simply isn't. And the fact that there's been 3 amendments now. And interestingly, I sent the Secretary of State an email asking for, I don't know, it was probably 12 different questions, specifically about the need to create 350 capital reserve funds and what were the other options. So I'm glad that was taken into consideration, but insurance is one of the most complicated topics. I think you all know this. You see bills on this all the time. And to think that this is so hastily being brought forth, it really needs to be studied more clearly. I wanted to leave you with one thing, a couple of things. One was we talked about return of surplus. Clearly, this law would have probably created more of a problem, but that's besides the point. But when there is a return of surplus for those 2 years, all these municipalities and school districts and counties, they have to issue hundreds of checks to all of the employees who contribute and to all the retirees. And then you have to try to find these people because you don't have records where a lot of these retirees are. So it becomes a nightmare on the administrative end. I believe that there is a need for regulation of insurance risk pools. I concur with almost everybody who said so before, where it needs to be under the insurance department. I worked in the insurance industry for 30 years, and if this is not an insurance department matter, then I don't know what is. So with that, I want to wish you a good afternoon and thank you.
Thank you. Kate McGrath?
Good afternoon. My name is Kate McGrath. I'm the Human Resources Director for SAU 19, Goffstown and New Boston. I will change my prepared remarks because so many different events have been brought forth today, especially the amendment, and I will keep it simple. I am here to speak to the fact that risk pools are a critical piece of what we do. So in light of this legislation, we have started the process of seeking our other alternative options. It is complicated, it is difficult, it is challenging. Risk pools provide us with incredible service that is incredibly important as a public entity. I also support common sense legislation. A minimum in terms of a threshold for reserves makes sense. I do feel this legislation has been rushed through, and the continued amendments at the last minute, I think, again, speak to that. And I thank you for hearing all of us today.
Thank you. Tara Tucker.
Good afternoon. My name is Tara Tucker. I currently serve as the Chief of Police in Greenland, New Hampshire. I'm here on behalf of the town of Greenland, myself as a resident in Nottingham, and for the New Hampshire Association of Chiefs of Police. And we are opposed to SB 297, which, based on what everybody said, I agree with a lot of it. So I will just go over some points that perhaps they hadn't mentioned. I've been back wanting to talk because every time Rep. Pressa asks the question, we are, last year in 2024, the town of Greenland decided we need to save money. We could go out onto the free market to commercial insurance and try to get a good policy. And we found a policy. It was an out-of-state company. And it started, we decided it in the fall of 2023. We started January 1st, 24. And we were promised same coverage that we had now, but at a discounted rate based on this company that was a third-party administrator. The results that we got last year was the employees were dealing with providers who weren't paid correctly or in a timely manner. Increased denials, prior authorizations on everything that we had never experienced before. Significantly more resources were used by the town finance person in trying to find out what the status of the bills were, pay the different medical, dental, wellness programs, the HSA, on and on. We learned after probably 3 months that the out-of-state company weren't even following New Hampshire insurance laws. They weren't using the forms that were required. So we went to the Attorney General's office and the insurance and said, how do we figure this out? Long story short, we did not save any money as a town. The employees were very upset. We had been with them for 4 months. We had to petition Health Trust to take us back because there is part of the contract that if you leave Health Trust, you can't come back for 2 years. Luckily, there was a loophole. If you could prove that you were promised more than what you got and they didn't support the current employees or the retirees, that we could come back within the first 6 months. July 1st hit, they allowed us back, and we will never forget that experience, ever. The risk pools for a small town is so important. There is no way to go out on the market for the majority of towns in New Hampshire and receive the kind of care and the kind of product that we can through a risk pool, not for anywhere close to the money. So the firsthand knowledge I wanted to bring, and we were able to be offered coverage. It just couldn't compare. It was, we will never look back if we're able to stay with Health Trust. As far as the 4% for budgeting for small towns, I think you understand, even if it wasn't specifically said, that would be very, very difficult in a town to be coming up with 1% and 4%. And then if we had more usage, to come up with another percent that wasn't budgeted for. It's very, very tight budgets for small towns. And I think it would be very difficult for the taxpayers to understand these changes as it goes back and forth. And the last thing that I don't think was mentioned at all today is that emergency services are dealing with the crisis of not being able to hire and retain people. It is really, really important that we not have any barriers to recruiting more people and to be able to hire more people. And this change in benefit would do just that. It would be just another hurdle of why would we go and work in that field? It's a difficult field anyway. So if you think in the vast majority of unions of just public employees, they all pay percentages of the healthcare that you get. So if we end up going on a free market and the cost is astronomical for the town, the cost is astronomical for the employees, we just won't be able to recruit and retain. And we're already in that spot. So please just remember that as you make some decisions. We agree as the chiefs of police that it would be great if someone could consider moving it under the Department of Insurance. It just makes so much more sense. But as it's written now, and I guess I probably don't have all the amendments, but as it's written, we would really, really recommend an ITL vote. I'd be happy to take any questions. Thank you very much.
But and for the record, her name is Representative Gibbs. You're looking at when you said Preston, I said, "What? I haven't seen him all day."
He's been in the corner.
Okay. Okay. Yeah, I'm down to 4. Okay. Jeff Dowd. Going once, going twice, gone. Shaylee Connolly from Holderness.
Thank you for your time and presence still at this late hour. My name is Sheila Connolly. I live in Holderness, and I have served on our select board there for 3 terms. I have also served on our Conservation Commission forever, and I am now a member of the New Hampshire Municipal Association Board of Directors. I did serve during the very tumultuous years for LGC when we had all kinds of fun and excitement. And I just want to say that I feel like if the Secretary of State's office is truly coming from a place of care and taking special look at this, then it should be done with none of the acrimony that happened back in the day. And I feel like that acrimony is being carried forward in a new formation. And I'm very concerned about not only our municipalities, but what it says about where we've been for the last 15 years. Like, if it's not working with that particular cast of characters, maybe it's time to change. I thought when we got through that whole mess, it was in our rear view mirror and we were moving on to a new place. And here we are again, and it feels like PTSD is going to set in. So this is not a great situation for the state of New Hampshire, and our small towns and communities don't have the resources to be here to testify, to take care of this. So I just wanted to come today to say, please don't, this is too early. It's not baked yet. It's not ready for prime time. So we need to figure out a way to slow this down and get it right and do it so that we can go forward for 20 years in a place that we all feel good about, our municipal partners. That's it.
Perfect. Thank you very much. David Moore.
Members of the committee, Mr. Chairman, thank you for the opportunity to speak. My name is David Moore. I'm the town administrator for the town of Stratham. I've been there for the past 6 years. I've served a total of 21 years in local government in New Hampshire and very familiar with the high quality product, stability, and appreciation our employees have for Health Trust. For those who don't work in local government every day, I think we need to bring back to mind the larger context here, which is what you're dealing with is very huge and very complicated. The number of covered employees in New Hampshire that are affected by the by health trusts under health trust coverage is 72,000 covered individuals. That is huge. You've asked the right questions, in my view, about what the experience would be if the small communities and some of the medium-sized communities were on their own in terms of accessing coverage for their employees. The reason why you don't have 234 people behind me right now is because many of those have not done the work to get to the point where they can answer that question. And that's because their renewals are in January. Some of them are in June. I think that's why you have the great animation by our friends from Coos County who presented earlier. So bring that to January. You have a lot more Coos counties here. I sat through this hearing as well as the hearing beforehand. I have much appreciation for what you're doing. I have to make an observation about that previous hearing. That bill was said to be by the Department of Insurance to be 3 years in the making. There's a reason for that. The content in this hearing today was the type of content you would hear in an administrative adjudication hearing with a rulemaking entity that is frankly probably more prepared to absorb some of these things. So this is on the wrong track. It is obviously on the wrong track, and it is coming at a time for New Hampshire local taxpayers that frankly could not be worse. And come January, when those November bills go out and we're looking ahead to next year, you're not going to want any part of messing with the $500,000 premiums the town of Stratham pays on behalf of its employees, because absent the health trust partner in New Hampshire, it is going to be much worse. Thank you.
Thank you. Michael Branley.
Thank you, Mr. Chairman and members of the committee. My name is Michael Branley. I am town administrator for the town of Windham. I'm here to speak in opposition to SB 297 as proposed. I have not seen the amendment. It does sound like a slight improvement, but still problematic. I'll submit my written testimony that was based on the legislation as proposed, but I'll just add that if this legislation were to pass and it resulted in health trust closure, which is something that's been discussed, as Mr. Moore had pointed out, you'll have a room full of communities like Coos County that are scrambling and looking at huge increases or having trouble finding coverage. So I will leave it there.
Great. Having no more cards, we will close the public hearing. We don't have to have this bill out until the end of May. My planning is that we'll have our first subcommittee May, probably, I think I'm still working on the date. So it's either going to be the first week of May or the second week of May. It'll give us enough time. And theoretically, I need to work on an amendment. And evidently, I need to have a very long conversation with Senator Gray.
So we're not having subcommittee next week?
So right now, for next week, we're going to have a light day because it turns out next week is school vacation week. And so for all the parents who have to be taking care of their kids, we're going to help them out. So we will meet on Tuesday. That's it. So all I'm going to do Tuesday, and I push the ambulance bill off because we don't really need to hear it too fast, anyways. So all we're going to do is in Tuesday morning we'll do the subcommittee for Senate Bill 19, which is the hotel bill. We'll do a subcommittee, and then we'll exec it. On Tuesday. So I'm hope everybody will show up on Tuesday so we can. It's technically business, but I'm carved it out uniquely. No, you need to be there for the exec session.
That's right.
I'm being nice by putting it all on one day. I'm breaking a golden rule, by the way. No Wednesday. Normally, I would have said the subcommittee would be Tuesday and I would exec it Wednesday. But then when it became, I've got all these requests for people who can't make next week. And before I know it, I said, to heck with it. Let's just get this bill out of committee. We'd absolutely have to have your vote on that.
John, I've got to ask this. So I'm going to guess that in 1987, they put this thing in the Secretary of State's office.